Important thing about one-guided system is a double contact concept. So 10 millimeter, 11.5 millimeter is the ultimate drill length. So 7 millimeter short drilling is done first. 13 millimeter path drill is used. So 10 millimeter. The full length is 13 millimeters. So according to the laser mark, up to the second line, 10 millimeter path drilling is done. Now up to 11.5 millimeters, that's the top laser black mark. Up to the laser mark, it is drilled. So the path drill is used to prevent the drill slip. One guide drill is a taper drill. So in the upper anterior, as we discussed during the discussion, path drill plays an important role. So 3.5 by 10 millimeter. So 3.5 by 10 millimeter one guide drill is used. And 4 by 10 millimeter drill is used to the full length. Number 13. .5 by 11.5. So 3.5 by 11.5 full length drilling for number 23. 4 by 11.5 is planned. 4 by 11.5 millimeter. Double contact. The end of the drill and the apex and the template need to be in contact. So double contact should be made to prevent the slipping. So we are checking whether it is a full length drilled. So when we use one guide drill, you may be worried about heat generation, but if you use the pumping action, according to our taste, the heat generation is not a problem in drilling. And the one guide drill that we use has very good cutting efficiency. So you do not need to be concerned about the heat generation, just to use the pumping action. So drilling is completed. Now implants are to be placed. So at number 21, 4 millimeter diameter and 10 millimeter long implant is to be placed. So the implant using no mount driver. So about 80% of drilling is done up to yellow line, and implant is placed. This is 4 by 11.5 at the position 23. So 80% of insertion is made. Looks like the stability is pretty good. So a drill extension was used before. Now it's all removed. It doesn't happen if we didn't have a drill extension. And it happened because of the drill extension that we used. Unlike one guide drill, no mount driver, there's a some 2 mm difference. So implant driver is used. Torque wrench is used, and the tactile initial stability is felt to find the final position. So hexa positioning and depth control is enabled using this driver. So initial stability is over 30 Newton centimeter, pretty good. And number 23 position, implant driver is used. Please open the mouth. Now it's inserted. Hand wrench, one guide template, and implanted driver's yellow portion is adjusted. Hex control and depth control can be done. And now the initial stability is over 30 Newton centimeter, pretty good. So the placement is over. Path drill is used by Dr. Son. So the sloped palatal bone on the bone, the step is made to prevent the slip. As Dr. Son said before, for GBR, the flap is open. Flap will be reflected and GBR will be done. Vertical incision and crestal incision a little bit palatally. So the tooth behind number 23, vertical incision for papilla preservation. So the distal tooth is implant. So to preserve a papilla, the incision is made like that. Vertical incision can be made from top to bottom, but Dr. Son made the incision the other way around, and you can make the incision as you want. In full thickness. I thought the GBR may not be necessary, but number 21 and 23 and the GBR was considered and decided to do it. So if it is placed, if they are placed in the palatal side sufficiently, it would have been okay, but there is some deficiency. So we open the flap completely to do GBR. Labial bone is quite thin. So there was a breach used for a long time, so the bone is deficient in number 21 and 23. Labial bone is very thin. And GBR is necessary. It can be okay at the beginning, but over time, resorption would occur. So when you do GBR, the full thickness is used here. Flap elevation is almost complete. On the palatal side, partial elevation is being made. As you can see, implants are positioned palatally. On the CT, you can see it is the planned positions. Cortical perforation is to be done before GBR for better blood supply to graft material. On the labial side, cortical perforation is made. So what drill are you using? Anchor drill for one guide. So anchor drill is being used to do cortical perforation on the labial bone to provide blood supply to the bone. When you do grafting, some doctors do it before surgery, but Dr. Son placed the implants with one guide, and this is maxilla, so not a lot of perforation would be required. So one guide template. So anchor drill is used to perforate the labial bone. So let me remove the soft tissue here for GBR. If soft tissue is involved in GBR, it's not good, so soft tissue is removed. As I said before, a pouch technique is to be used. Guide and bone tags are used. A membrane is fixed first, and then graft material would be put in. Os guide. Os guide is positioned. You don't really need to trim it. Is it 2 by 3? Yes. 20 millimeters by 30 millimeters, and bone tag is used to fix it. The bone tags in GBR kit can be used. bone tacks are used to fix the membrane. So bone tacks are included in the GBR kit. It is a bone tack. It is not bony screws. It's one size. So I was wondering whether it is 6 millimeters. So bone tacks are used to fix it. So it is fixed. No, it's not fixed. It's my mistake. So it should go in perpendicularly, otherwise it will bend. So alveolar bone is sloped where bone tack is applied. Usually I succeed. My success rate is quite high. So it is where nasal spine is located. So the position is not really favorable position. So I will do it again like this. Though it is near anterior nasal spine. Sorry about that. So, and I will move beyond the interior nasal spine. The angle is not very good, so actually this is bent. So also bone tack is good, but my hand is not working very well today. Number 23, it is fixed pretty well. So beyond the nasal spine, it is fixed. So I have never been unsuccessful like this before. So let me do it again. The bone tack included in GBR kit is used. So it'll be fixed at the side. Now it is fixed. Because of the shape of the alveolar bone, the angle was not really good. And we need to secure the volume by grafting. So membrane is fixed and a pouch is made. So upper side of the patient, the bone tack keeps bent, and I've never had this kind of problem before. Now it is fixed. AOS collagen is used for the grafting. So it is launched recently, AOS collagen for socket preservation. This can be used to make a shape. Below the membrane, the collagen is inserted. Looks like the volume is sufficient. So extra socket. Outside of the labial bone, a pouch is formed, and AOS bovine bone, AOS collagen bovine bone is packed in. So outside is important to keep the shape. So bovine bone, which is slow to resorb, xenograft is used. AOS collagen is used here. So volume is sufficiently secured. And holding onto here, and this will be removed later on the anterior side. It is fixed. So on the labial side, sufficient volume is secured, and the volume is distributed. Using the collagen membrane, a pouch is formed, so the form is made. So at number 23, the same. Over it, over the alveolar bone, it's bottom area of the patient. Now it is bent. It looks like the patient's alveolar bone is very hard. So extra socket grafting is almost done. And now internal socket graft and temporary abutment will be mounted first. Please open your mouth. Intrasocket graft material will go inside the implant. So before the socket graft, suction please. So inside the implants, we need to prevent graft material go into the inside of implants. Please open your mouth. So one guide is used and hex is matched when implants were placed, and the prefabricated we use a guide with hex positioning. Implant depth is controlled, so prefabricated abutment is connected, and internal socket graft. And before surgery, I plan to have allograft, but AOS collagen, the xenograft, is chosen over it. So inside xenograft, AOS collagen is put in the intrasocket, and abutments are connected so that the graft material doesn't go into the implants. And the remaining area will be fixed. One more bone tech at number 23. I believe it will be completed once it is fixed. Now fixation is completed. As you can see, there is some exposure. So one more membrane will cover it where bone is exposed. So Oss guide will cover it. So Oss guide is being cut, matching the defect. Are hydrated first. So it is hydrated first. It is a collagen membrane, so manipulation of it is easier. Open your mouth, please. And beneath the palatal flap, it doesn't require any stabilization. So for non-resolvable membrane, fixation is important, but this is a collagen membrane, so it is adapted to the form pretty well. Now the flap will be periosteal incision releasing should be done before raising the flap, but this is a pouching technique, so periosteal incision is made right now. Before grafting, periosteal incision can be made, but I usually do it after grafting. If you use Oss Builder, you can identify the surgical site better. So after the grafting, you can make it more tension-free. Periosteum is released tension-free. The flap is adapted. So you can pull it tension-free. So suturing before finish. So periosteal releasing incision tension-free. So it is not that we pull it using suture, it should be tension-free. So that will make wound opening less. And number 21, the most important area is where nylon suturing is used. The 40 nylon is used. So flap needs to be inside. The flap should be inside. So it's where papilla is. Now it looks like it is positioned pretty well. Through tension-free adaptation is achieved, and interrupted suture is good enough in this case. So between the two implants, as we expected at the beginning, if stability is not good enough, in the worst case, we would place one more implant, but over 30 Newton centimeter primary stability has been achieved, and pre-made, prefabricated abutments are connected pretty well. Now horizontal mattress suturing. As you can see, the flap is tension-free. Please open your mouth. So adjacent tooth is implant. So I need to do it in 2 sutures. In the crestal area, the incision is near the implant. As you can see, it is tension-free suturing. Now the surgery is almost complete. So proximal area before crestal, distal to vertical incision. Maybe 2 sutures for the vertical incision. Yes, that's what I want. So I'm applying too much force because I'm nervous. Yes, when we do live surgery, we get nervous, but you're doing pretty fine. So vertical incision is sutured in the distal side. So one more suture. Now I'm going to the proximal area. So a vertical incision is all sutured up, and in the proximal area, now surgery is almost complete. So when you raise a flap, so you can suture like this. We use a nylon these days. There's a reverse cutting. So in the attached gingiva area, suturing can be difficult, but he's doing pretty well. Temporary prosthesis can be adapted, and you can do the attachment later. We have another surgery, so he's pretty nervous. If we can give you enough time, it'll be better. But in live surgery, sometimes unexpected things happen, but without a problem, it is being finished. So the adjacent nut can be pushed in, preventing the suturing at the desired site. So vertical incisions are all sutured up. And now I can just work on here. So surgery is almost complete. Here, a little bit of tension. So it's almost tension-free, and the figure of 8 is used. Horizontal mattress suture was done once before. So we are running about, we started actually 10 minutes behind, so the surgery time is almost as planned. So we have one more surgery to do, and Dr. Son is rather hurrying up, and it looks like it's all done. So you can put it in. This is rather low. Please bite on it. So the implants are placed according to the plan, and temporary prosthesis is fitting very well. Thank you very much, Dr. Son. You had a difficulty with the bone tech, but thank you very much. So this concludes the surgery. Thank you, Dr. Son. He did a good surgery, calmly. Live surgery Q&A. will be done after Dr. Kim's surgery, inviting the two surgeons. Dr. Kim is preparing another live surgery. And let's hear from Dr. Kim how he is going to do the surgery.
Greetings, I'm Dr. Kim Yong-jin. I am extremely honored to take part in 2022 Osstem meeting Seoul's live surgery. I'm honored to do this together with Dr. Son Young-hee, whom I look up to, and I promise I'll try to do my best. Before going into surgery, let me talk about the surgical plan. This is 55-year-old male patient without any systemic issues. He has 3 implants placed by another dental clinic on the left. Today we're going to focus on anterior and upper right posterior area. This is condition before surgery. The anterior prosthesis is as shown in number 21. Severe gingival resorption can be observed. In 22, period condition does not look good. A guide is going to be used to place the implant in the upper anterior. Prefabricated 1-fit abutment and PMMA bridge is going to be used for immediate restoration. Guide is going to be used. Trios is going to be used to fabricate guide. Oral scan is sent to Osstem 1 Guide Center and merged with CT data. Prosthesis design is made. This is number 14, 16, and the anterior 4. The prosthesis design is made. Guide surgery is planned for immediate implant placement. In surgical planning stage, you can see severe labial concavity on the anterior zone. Appropriate implant diameter and length was chosen in 11. Due to labial concavity, I don't think the implant will be exposed, but the implant apex area buccal wall is going to be very thin. Hence, I'm considering augmentation. Bone width for 14 is fine, and in 16, implant is going to be placed like this. If you look closer, look, a crestal approach is needed here. 5.0 by 8.5 millimeter implant is going to be placed. The residual bone is about 4 to 5 millimeter. One cast will be used for sinus lift for implant placement. Template design. On both sides of the anterior, in number 2, in 12 and 22, immediate implant placement after extraction will be done, and in 14, 16, simple implant placement will be done. One guide will be used for number 12, 14, and 22, and in 16, one casket will be used for crestal approach for implant placement. There are additional things to consider in number 12. Apex to the implant, the residual bone is very limited. Therefore, in a simple manner, I will not reflect the flap extensively, unlike Dr. Son, and am going to do contouring augmentation. The biggest area is number 21. Because there's stark difference in gingival level, I'm not going to place implant here, but for aesthetic anterior prosthesis, augmentation is needed. I need to consider the softer tissue, therefore, in a simple manner, socket preservation is going to be done. In number 12, on the apex side, contouring augmentation will be done using tunneling technique. I'm going to share a similar case. In number 11, extraction was done. In number 22, it looks very similar. Because there's concavity, guided surgery was not here. Implant was placed first, post-op panoramic image and PA was taken, but it looks fine. In post-op CT, it is partially exposed. In order to augment it, I could have opened a big flap, but a very small vertical incision was made distal to the vestibule and the membrane was lifted. A pouch technique was used. Rather than granule type, I used a collagenated graft material, AOS for contouring, augmentation, and the apex of number 12. I'm going to do something like this. I did not use membrane. I'm not going to. You may be curious of long-term prognosis. Post-op CT, 2 weeks, 3 months after final prosthesis delivery. As you can see on CT, membrane was not used, but the bone augmentation was done nicely in the apical area. Labial contour is nice. This is possible because AOS collagen contains collagen and stabilizes graft material. Even if you don't use membrane, such healing can be achieved. This is another smaller case. Number 22 is problematic. On the apex of side that there is severe concavity. One guide was used. In planning stage, I assume the apex area is going to be very thin. Extraction was done very carefully. One guide was used to drill and place implant like this. Vertical incision was made distal to the vestibule like this, and I did a full thickness flap elevation. Collagenated graft material was used for augmentation. I'm going to show this when I do the live surgery. This is the most difficult case. In number 21, gingival recession can be absorbed. The difference of gingival height with adjacent teeth is too stark. How can I overcome this? I can do connective tissue graft, but I didn't think it would be predictable. Collagenated graft material was used to do socket preservation. It's a similar case. In number 21, I'm not going to place the implant here, but for soft tissue contour below the pontic base, I'm going to use collagenated graft material for socket preservation. Pontic base in a ridge wrap form will be used to protect that area. After 3 months, it looks slightly different, but because the pontic is in ridge wrap form, the ideal gingival regeneration was achieved. This is final prosthesis. Gingival regeneration was achieved without a problem. In this case, the gingival recession amount is smaller than the case today, but I'm going to take the same strategy. If the gingival recession is too much, even if you use collagenated graft material like AOS, there could be stable soft tissue regeneration with the epithelialization superior structure, but if there's too much exposure, it can lead to unwanted consequences. The plan for today is like this. So for this patient, 2 implants were planned for number 11 and 21, but the implanted position and distance of implant in number 11 was not good. After placing implant in number 21, final prosthesis will be connected to number 12, which was already placed. In number 11, gingival recession is excessive. I used collagenated graft material for socket preservation. This is panoramic image. 11, number 21 extraction was done, and in number 11, as shown, if the patient has chronic period disease in the anterior area, there is granulation tissue in the palatal area. Due to chronic periodontal disease, soft tissue is thickened. I do not remove such granulation tissue and attach it to the buccal flap and make a space. And in the socket, I remove granulation tissue fully, and I use collagenated graft material. After I use the granulation tissue, which I've attached to the buccal flap like a dressing material, like a membrane. Today, major things to look out for is that I'm going to use 2 implants using a guide in an area where there's apex concavity. In number 12 and 11, AOS collagen will be used in a tunneling technique manner for augmentation. In number 21, where there is severe gingival recession, primary socket preservation will be done using AOS collagen and the granulation tissue on the palatal side for socket preservation. Thank you. This is a second live surgery. Dr. Kim Yong-jin. Let's begin the live surgery. Dr. Kim, you can start. Yes, I'll begin. As mentioned in the briefing, I'm going to extract the anterior teeth first. The anterior teeth with a bridge, it's very damaged. Number 21 is going to be extracted. There's very little attached. Just with forceps, tooth is being extracted. On the apical area, granulation tissue is removed. I'm going to adapt the template to say as mentioned. We make a template before extraction. This is one guide, the template. I think it fits well. It's accurately adapted. In number 21, socket preservation is going to be done, and soft tissue amount may not be enough. So in number 6, I'm just going to graft connective tissue graft as well as epithelium tissue. I'm going to use tissue punch first. Say The diameter of tissue punch is 6.0, so I'm going to use it first. Later, in number 21, for socket preservation, Dr. Kim is removing the tissue without using guide. Are you using 6.0 diameter? Yes. To the left. Why the tissue punch is used? On the crestal side, the soft tissue is removed. For number 21, this is going to be used for socket preservation. Guide template is adapted. First, I'm going to do crestal approach. The area with the least amount of residual bone. The initial drilling depth is 3 millimeters, 7 millimeter stopper, and 4 millimeter stopper. This is one casket, a 7 millimeter drill with a 4 millimeter stopper. So Dr. Kim's going to drill up to 3 millimeter. Tissue punch has already been done. 3.1 one cast drill. So 4 millimeter stopper. So drilling is done up to 3 millimeters. 3.1 millimeter one cast drill. Drilling up to 3 millimeter is done. 3.8 one cast drill. So before penetrating the sinus of floor, Dr. Kim is expanding more. 3.8 by 4 millimeter with 4 millimeter stopper. I'm going to increase the drilling depth. This is 3 millimeter stopper. Drilling is going to be done up to 4 millimeter. The final drill. So it is better to penetrate the sinus floor like this in order to preserve the sinus membrane. I don't think it has been penetrated. I'm going to use 2 millimeter stopper and going to use 5 millimeter drill. 3.8 by 5 millimeter drill is used. One cast drill. Unlike a cast drill, there is difference in stopper. It has not been penetrated fully. I'm going to use 1mm stopper.
지금 현재 쓰시는 원카스는 7mm고요.
The one cast drill is 7mm one cast drill, and 1mm stopper is used, drilling up to 6mm. I think it may have been penetrated.
보시면 네, 관통됐습니다.
Yes, it has been penetrated.
고요. 수압 거상하고 간단히
Sinus lift is going to be done, and implant will be
수압
placed.
거상은 보통 이제 하이드롤리프트 할 때
When you do hydro lift,
시리즈나
you use a 3cc syringe or 5cc syringe. Dr. Kim is using 5cc syringe.
할 때
When you do aspiration, you need to make sure that the blood is coming out. The residual bone is about 6mm, and I'm not going to do excessive sinus lift.
저희가 지금 5에 8.5까지 잔종골이 약
The residual bone is about
5 내지 6mm까지
5 to 6mm.
빨리 가죠. 5에 8.5. 임플란트 생략하겠습니다.
I'm going to place the implant.
본그раф트는 없이 그냥
Are you going to do it without bone graft? Because residual bone graft? Yes, because I'm going to place 8.85
위에 있는
implant.
예, 그 카스트리 원카스트리
One cast drill was used for drilling. Membrane was lifted, and below that,
본그раф트 없이
without bone graft,
약간 텐팅 하듯이 올리는
almost
거로
like tenting,
지금 식립을 하고
implant is being placed.
지금 5.0에 8.5mm 심으신
Did you
거죠?
place the 5.0 by 8.5? Yes.
TS3 5.0에
TS3 5.0 by 8.5. It is being placed 80% with engine. Implanted driver is used to get the final position.
저희들이 이제 뎁스 컨트롤 및 이제
Depth
원가이드
control.
템플릿을 하게 되면
If you use one guide template and get to the yellow part, you can get the right hex.
그렇게 해서 부가적으로
Additional
서포팅을 좀
support in order to get that. In the interior area, there can be slipping. I'm going to use it like a tent pole. It's like a vertical stop, yes.
앵커 역할
It's like a vertical anchor.
보면 지금 임플란트 드라이버를
Implanted driver is used
원가이드 템플레이트가 혹시라도
so that the one guide template does not slip and slide in the interior area.
임플란트 드라이버를
Implanted driver
그 16번 부위 임플란트 부위에다가
is in number 16 where implant has been placed.
그다음에 이제 14번 부위가
In number 14,
티슈 펀치 없이
without tissue punch, are you going to do it? Yes, I'm going to do it without the tissue punch. Initial drilling is done in number 14.
그다음에 3.5에
3.5 by 11.5 millimeter.
원가이드
One guide drill is used.
3.5에
3.5 by 11.5.
계시고요.
골질은 나쁘지 않은 것
The bone quality seems to be okay, so I'm just going to do normal drilling.
다음에 4.5 원가이드들을
4.5 one guide drill.
경의 임플란트 생략할 거고
Because 4.5 diameter implant is going to be placed and the bone quality looks okay, 4.5 by 11.5 millimeter drilling is done. The bone quality is good. In one guide drill, the amount of cortical bone looks very good.
지금 이제 14번도
In number 14, drilling is done.
안쪽에 살짝 이리게이션 하고
Irrigation is slightly done.
TS3
TS3 4.5 by 11.5 millimeter implant will be placed. 4.5 by 11.5 millimeter implant.
엔진으로 약간
It is placed 80% with engine, and then the implant driver is used to get the final position. Torque wrench is used.
지금 보면 어시스트가 옆에도
You can see that the assistant is holding the one guide template so that it does not slide.
최종적으로
Implanted driver is used to get the final position. The torque seems to be good. It seems over 30 Newton centimeters.
뎁스 컨트롤
Implant depth control is being done.
이제 2개 임플란트 신경.
2 implants have been placed. Now we're going to move on to the anterior region.
임플란트 드라이버를 그대로 꽂아서
Implant driver is used like a vertical anchor.
같습니다. 식립한 임플란트를 이용해서
Using the placed implant,
플레이트를 잡아주는.
this is used to fixate the
그
plate.
환자분이 그 CT상에서 보셨던
On
것처럼
CT as shown, the patient has a apical concavity. I'm not going to use path drill. I'm going to use initial drill. For soft bone, I'm going to use straight 2.2 drill, initial drill for soft bone. It's a straight form. Initial drill is originally tapered form, but the 2.2 initial drill for soft bone is used. At times, the full depth drilling is not done because of the palatal bone. In this case, you can use flattening drill. When you use, what is different with the path drill? If you use path drill, as Dr. Seoul, if the root is long, you can hit the palatal wall. But if there is concavity on the apical side, there can be over preparation, so it can be unfavorable to get the primary stability. In the Q&A session, we will revisit on this topic. If the cortical bone on the crestal side is thick, the drill may not go in full depth. You can use a flattening drill. So you can use flattening drill here like this to get more cortical drill. Initial drill, you need to check whether initial drill goes in full depth. You need to make sure that initial drill is not going in fully because it is hitting the bone, palatal bone. 2.2 by 11.5 drill. 3.5 is also for soft bone. 2.2 by 11.5 millimeter soft bone initial drill is used.
골질이 안 좋고 이미디어트로 프로그램 레스토레이션 연결할
예.
거예요. 언더드릴링을 계획했는데
I originally planned for under drilling because bone quality was suspected to be not so good, but it's okay. I'm not going to do full depths. I'm going to drill up to 8.5 on the apex area because the patient has a lot of concavity. I think this will be a strategy to prevent perforation. 3.5 by 8.5. So you're widening just the superior part. TS3 is a taper design, therefore, just on the top of the prep is being done. Initial for primary stability, he has chosen this strategy. Based on his experience, he has taken this strategy. Implant diameter is 3.5 by 11.5. For placing 11.5 millimeter implant, he has drilled up to 8.5. TS3 has sufficient self-taping capacity and it is sufficient for anterior use. Just with a 2.2 soft drill, it can go up to the apex area. I'm going to do under drilling in the apex side, so the primary stability is good. Primary stability looks good. Over 30 Newton centimeters. When you treat the anterior zone, TS3 implant can slip towards the labial side. You can see that implanted driver is used here as well. No mounted driver is used to place the implant about 80%. It is removed. Implant driver is used to get the final implant position. The primary stability looks good. Implant have been placed. Before I do graft, before I do socket preservation, I need to adapt first. To see how the prefabricated prosthesis fits, in number 4, I used a transfer stock abutment. In number 14, stock abutment, stock transfer abutment is used.
헥사가 있는 어버트먼트겠죠?
Is it an abutment with hex? Yes.
저희가 원가이드로 헥사 커트로 해놨기 때문에
Because one guy was hex cart.
지금 보시면
잘 맞는 것 같아요.
I think it fits nicely.
깡 물어보실까요?
Can you bite?
아,
Say yeah. I think it fits nicely.
지금 14번은
In number 14, immediate provisional was provided. Say yeah. In number 16, Castrol was used and it touched the sinus. Therefore, healing abutment is connected.
직경 6.0에
6.0 diameter healing abutment is connected.
이제 전치부는 아무래도
In the interior area, in order to avoid the apical concavity, I made a 1-fit abutment. I think it fits nicely.
템포라리 만들어 놓은 거
Temporary provisional is being adapted.
지금 뭐 우리가 원했던 부위에
In the desired area, it has been adapted nicely.
먼저 이제 어댑 해보고
I'm going to do adaptation.
지금 템포라리 프로세스 어댑테이션만 하고
Provisional is being adapted, and now I'm going to move on to graft. In number 21, socket preservation will be done. It fits nicely. Say ah.
계획하였던 대로 지금
As planned, the implants have been placed.
원장님께서는
Dr. Son,
타입 2 디펙트 라비얼
he had a
말씀하셨어요.
type 2 patient with no labial bone. I wanted to see type 1 socket preservation.
자 이제 먼저 발치창에 그래프트를 좀
In the
시행을
socket, I'm
하겠습니다.
going to do graft.
그 에이오스 콜라겐
AOS collagen will be used.
살짝 다 물어보실까요?
Can you close slightly?
조금만.
Say yeah.
지금 보시면
If you look here,
임플란트 내 측에 본그라프트 머티리얼이 들어가지 않는
in order to prevent graft material going in, the implanted driver is connected. In the cervical area, gingival contour is very important.
지금 역시 AOS 콜라겐
AOS collagen is used.
콜라겐이 섞여 있는 그래프트 머티리얼
I use collagenated materials.
반응들이 좋으니까
It has good soft tissue response even if it is exposed. Epithelialization can occur, therefore it can be favorable. When I use the AOS collagen, even if it is exposed, the epithelialization occurs very quickly.
지금 보시면 그 임플란트 그 내부로
Within the implant
커넥션
and
쪽에 본그라프트
towards the internal connection, in order to prevent the graft material going in, implanted driver is used.
시간에는 아마 임세 원장님들 커버
During the morning session, cover screw was used, but now one guide the implanted driver is used. The good thing about implanted driver is that below the guide barrel, it is narrow, so it's good. It's a good tip. In general,
장착하기도 하는데
at times you use a cover screw, but if you use this technique,
드라이버랑 달리
unlike the general driver, one guide the implanted driver, the lower portion is narrow, so you can put a sufficient amount of graft material to the internal socket.
이렇게 약간 모빌리티가 있는 치주 발치를 한
In the
경우에는
case where there's mobility,
리세션이 없다 그런다면
if there's no gingival recession,
방법으로 주로
in order to prevent recession, you can do dual zone graft to prevent the gingival recession. In that sense,
친화성이 좋으려면 콜라겐이 섞여 있는 그래프트 마테리얼들이 훨씬 더
Collagenated graft materials can be more favorable.
지금 에이오스 콜라겐 같은 경우는
In the case of AOS collagen, soft tissue regeneration is very good. You do not use alloplastic? Yes, I don't. Because there's organic component, I don't really use it. It's unfavorable to graft outside the socket.
보면 22번
In number
12
12, graft has been done. You can see that AOS collagen doesn't crumble. I think that's really attractive.
저희가 임플란트 드라이버를
Implanted driver, even after it is removed, you can see that the AOS collagen material, the form is being maintained.
하나 더 꺼줘. 이게 미리 어댑을 안 해보고
If you do not do adaptation and then do dual zone graft and then do adaptation, then it's very difficult to make sure that the adaptation is done nicely. So you do try in first, and because you have confirmed that it adapts nicely,
코렉션을 하시고 그래프트를 하시는 게 좋습니다.
you can proceed with graft. I think this is an important tip
저도 지금 임플란트 드라이버 해놓고
because
에이오스 콜라겐
you're using the implanted driver. It's my first time seeing someone use implanted driver and using AOS collagen. I think this is based on his long years of experience. It's a great tip. As you do implanted treatment on the implant connection area, at times it can be quite troubling because it goes into the connection area. In doing socket preservation and implanted treatment in type 1 socket, AOS collagen can be an issue if you do it without using the implanted driver. AOS is used sufficiently.
듀얼존으로 그라프트를 하죠.
Dual zone graft is done.
에이오스 그래프트 마테리얼 자체
In the case of AOS collagen, porosity is good, so network is formed nicely. It's easy to handle.
최근에 아마 에이오스 콜라겐이 출시되고
Recently,
괜찮은 것 같습니다.
since AOS collagen has been released, I think it has gained a lot of popularity. I recommend you use it in your clinical practice. Temporary prosthesis is being adapted. If you do this, you can get the cervical gingiva contour that the patient had before extraction, and additional support can be gained with the graft material. Therefore, based on my short clinical experience, I think it's a good idea. Torque wrench.
돌리기가 쉽지 않을 것 같은데.
It's difficult to do it with your hands
사실 그 핸드 드라이버보다
rather than a handed driver. The head is smaller, so it's not easy. I hope there's longer one available.
미니 임플란트니까 15에서 26 정도로 템퍼러니까
This is an immediate implant, 15 to 20.
임플란트 식립 및
Mini implant placement.
템포라리 프로세스까지
Temporary prosthesis has been done.
15에서 한 20죠.
15 to 20 Newton centimeter.
이렇게 하고 나면
Once this is done,
원핏 어바트먼트를 사용하게 되면
because if you use a one-fit abutment, cervical contour can be maintained and emergence profile can be given. I think a dual zone graft is very easy for this purpose. Irrigation,
지금 원장님 말씀하신 대로
as you have mentioned, the AOS collagen
오버라인 무코자가 덮이는 게 굉장히 빠르더라고요.
overriding mucosa covers very quickly.
이쪽이 아무래도
In this area, because although it is below the pontic base, there's a lot of recession on the palatal side. There is a sound tissue here. I'm going to use that
스페이스 만들고요.
to secure space,
에이오스 콜라겐 밀어
and I'm going to put some AOS collagen.
발치 후에
After extraction,
탈 쪽에 있는
on the palatal side, granulation tissue will be used. You're going to move it to the labial side, yes?
좀 본이 많이 됐기 때문에
There's sufficient bone, so the granulation tissue on the palatal side is going to be moved to the labial side using the incision.
바깥쪽으로 그것도 역시 많은 경험에서
I
나온
think this is
노하우인 것
based
같아요.
on your long-term experience.
이렇게 그래놀 티슈를 저렇게 옮기는 게 처음
Detaching the granulation tissue, it's not easy.
메스를 이용해서 확실하게
So he's using a new method to detach for sure.
인플라메이션이 있지 않은 상황이라고 한다면
Unless there's acute inflammation, I think chronic granulation tissue, because it has good fibrosis, I think soft tissue response is going to be good.
멤브레인 커버리지가 할 수 없는 상황이
If membrane coverage is not possible to maintain volume rather than a soft tissue, I think it's better to have bony housing. In this case, using collagenated materials can be of great help in this instance.
지금 에이어스 콜라겐을
AOS collagen is used.
아무래도 이렇게 몰더빌리티라는 게 되게 매력적인
Moldability is very good.
아무래도 저희가 파티클을 집어넣게 되면
If you put in particle, it's not easy to put in like this. And if you do suture, it's gonna collapse a bit. If you can maintain this much contour, it's going to be good.
그렇게 되면 이게 프라이머리 클로저가 좀
Primary
어려울 거라고
closure
생각을
can
해서
be
아까
difficult.
놓은 것을
Therefore, I'm going to use the tissue punch material.
정교하게 본을 만들고자 할 땐 이런 방법을
In trying to make a bone intricately, but because it's below pontic, this is for aesthetics, it's okay. I think after doing guide surgery, all procedure needs to be simple.
예, 아까 마치 티슈 펀치로 띄워놓은 조직이
Using the
딱
tissue
알치와의 자기 사이즈에 맞는 거네요.
gained from tissue punch, it fits perfectly. I think we are getting lucky here.
보시는 것처럼
As you can see, collagen holds blood very nicely.
콜라겐이 섞여 있는 시판돼 있는
In collagenated graft material, there are many options available.
그런 포로시티가 안 좋으면은 아무리
If the porosity of the molecule is not good, the ability to hold blood falls. In that sense, AOS collagen is very good to be used clinically.
많은 선생님들이 좀 사용해 보시면
Please go ahead and try.
예, 지금 뭐 거의 다 수술이
I think surgery is almost done.
지났나요?
How many minutes have passed?
예, 지금 이제 시간은 거의 다 되긴 됐습니다.
I think we're almost right on time.
이제 그냥 마무리만 하시면 될 것 같습니다.
Now you just need to close the case.
예, 지금 보시면 아까
You can
그
see
신경권 부위에서 떼어낸 그 조직을 이용해서
The soft tissue gained from number 16 is now being attached. Because on the buccal side, the root was exposed, the soft tissue defect was significant. This is used.
두꺼운 팔레탈 쪽에 먼저 고정을 해주고요.
So I'm going to fix it towards the thick palatal area first.
어떻게 보면 부가적인
In some sense, without additional CT graft, this is a method to avoid CT graft. If additional connective tissue graft is necessary, yes, you may do it, but I'm not an excellent surgeon. I'm not really comfortable about doing CTG. Periodontists think pre-gingival graft is very easy, but as a surgeon, CTG is not really easy. If it's difficult for you, Professor, then what would it be for me? In number 16, tissue punch was done. 6 millimeter tissue punch. Did you get it separately?
사이즈별로 쓰고 있어요.
I have all sizes of tissue punch.
오스템에서 팔고 있는 마이진 거그 드릴에 티슈 펀치
The
세트가
tissue punch scent from Osstem is available. It's for Reisinger.
세트를 구매를 해서
I bought it.
것들도 그렇게 세트로 놨죠.
And there's also a trapine burr set for different diameters.
지금 50 나일론 쓰고
50 nylon is used.
50 나일론을 이용해서 지금
50 nylon is used. Suture is almost complete.
지금 보시면 팔라탈 쪽에 있는 그래놀 티슈를 완전 라비알
The palatal granulation tissue was moved to the labial side, and on the labial side there was a lot of soft tissue lacking, and now it's been compensated for.
예, 아마 보시는 많은 선생님들이 새로운
I'm sure you got a lot of clinical tips.
저희들이 보통 보통 이제 팔라탈에 있는 그레인 티슈를 이용한다 그래도
Using palatal granulation tissue.
않았던 분들도 많지 않을까
Some people may have only thought of it as a vague idea, but as we watched Dr. Kim do it, I think it has dawned on many people that that's possible.
디스차지가 심하거나
If there's severe post-discharge or if there's a lot of inflammation, it's a technique that cannot be used, but a chronic granulation tissue, you can use it because it has fibrosity.
어큐트한 인플라메이션 상태에서 플랩 자체가 플랩이
Unless it is acute inflammation and if the flap is flabby, you will not be able to use it. But if the patient has a chronic condition,
옮겨놨을 때 크게 문제가 없지 않나.
then it will not be a major issue.
잘 마무리되고 있습니다.
Now surgery is being proceeded nicely.
마지막 한 방에만 더 보내고 수천원.
So I'm going to do suture just once more.
성공적으로 다 잘 마무리된 것
Surgery has been done successfully.
마지막 봉합이 있고요.
This is the final suture.
그 다음에 한번 다시 어댑테이션.
I'm going to do adaptation once again. Can you give me the provisional?
예, 잘 맞고 환자 한번
If it's nicely, can you have the patient to do occlusion? Pontic base, I think if you can get this kind of gingival contour, I think this can be addressed prosthetically. Congratulations on successful surgery. Now we'll move on to Q&A session. Thank you.
네, 예, 라이브 서저리 두분 다 잘 마무리.
So we have successfully completed the live surgeries. Dr. Kim may take time. He needs to take CT. So we will do Q&A first with Dr. Son. So this is your first live surgery, right? Yes. So it is your first time in Osstem meeting. It must have been nervous, right? Yes.
저희가 질문 들어온 거 먼저 한번 좀
So let's look at the questions that we received.
일단 김효정님 같이 말씀하시면 좋을 것 같고요.
And there are some questions to be addressed by Dr. Kim as well. So
사실 파우치 테크닉을 쓰셨는데
you used a pouch technique. So they could have been done flapless. So that is a question. Can you answer that? Flapless is ideal and best. In the planning step, the outer surface of the implant to the labial bone outer surface, the distance is important. If it is more than 4 millimeters, internal socket graft is good enough to respond to remodeling. But during planning, if it is less than 2 millimeters and the gap is very small and the distance to the labial bone was very small, so external socket graft was a must. Therefore, from the beginning, from the planning stage, GBR was planned. So at the beginning, internal socket graft, if the allogenic graft was considered, but the AOS collagen was chosen. So you use AOS collagen quite a lot, yes. How do you use it? EOS collagen is a graft material, 10% collagen in it. By using it, there are many cases that can benefit from it. Internal circuit graft, dual zone graft can be done benefiting from it, and it is not dispersed. And the collagen itself can have much more blood than its own volume, so it helps the blood supply, and bone regeneration can benefit from it. So for circuit preservation, it is very good. So I use it really a lot. So I talked about it during surgery. One of the questions, cortical perforation is done with the GBR before placement. What about you can raise the flap? Yes, that's a good idea. When I originally planned, when I raised the flap, template can be less stable. So I decided to place the implant first, and after the placement, the cortical perforation was done. Usually, it is beneficial if you do it before placement. Non-traumatic extraction. For that, periotome and malleting. Regarding that, there is some question. Do you always use a periotome? And when you do it, do you always use mallet? Yes, I always use mallet for periotome, even though it can be just a small amount. In this case, number 23, and the treatment is done. So PDL space is very small in that case. So if you just extract labial plate, when a labial plate is thin, that is problematic. So to avoid that occasion, when endo-treated or PDL space is very thin, I use it. So in this case, a labial plate is thin. So in case of Dr. Kim Young-jun, a forceps was used to do extraction. So if you use a forceps only to luxate the tooth, the labial bone can be fractured. So that's why periotome is used. So you can refer to this when a labial plate is very thin. When you do forceps delivery only, and if you do luxation with forceps, labial plate can be broken. That would be a problem. So in this case, a pouch is used. You already talked about it. So you remove the bone tech, only the upper one, and the rest remain there. So releasing incision is done. That can invite post-surgery swelling. Do you have any medication or know-how to address it? I don't really have it. There are many ways to reduce swelling. Usually, medication, hexadesamine, can be used after this surgery, and the cold pack or compression can be applied, and there has been not a major problem when I use them. And another medications can be done, but dexamethasone is something that we use. So what is the dose and for how long? According to papers, tapering is not necessary for short-term use. So 1 millimeter 3 times a day for 3 days. So if it is used within a week, the steroid can be used without tapering. Bone techs are used quite a lot. Is there any special know-how for that? The questioner is talking about the malleting type. I believe he's talking about bone tech. GBR kit bone tech of Osstem. Actually, this is my first time to see it is bent. the basal bone of the patient is very hard. I checked it, and I never experienced this kind of bone tech bending before. In the maxilla, bone tech is good enough, but in the mandible, if you are to use a bone techs, drilling may be a little bit necessary. For bone screws, Osstem bone screws is useful in fixing membrane in the mandible. So the short one, I believe it's 1 point. I can't remember it from top of my head. So bone tech is used a lot. In the maxilla, bone techs hardly get bent, but anterior nasal spine or bone is much harder than we expected. And Dr. Kim has just joined us. Thank you very much for the wonderful surgery. Dr. Kim, so what's your impression of the live surgery?
I felt really nervous, and I learned a lot from Dr. Son, so I felt pressure. I have a joint question for you. There are many questions on the live chat. Dr. Son, you used the path drill, so we talked about that. The path drill, you both used it. Dr. Kim, you did not use a soft drill. You just used initial drill for soft bone. Could you elaborate on that? What is the path drill like? Path drill, I used it. There are two types, 7mm and 13mm. The reason is because Osstem one guide's concept itself is a double contact concept. So when you do drilling, the template needs to be in contact with the drill as well as the bone to minimize deviation. In a sloped surface, you need to do initial drilling, especially in the case of immediate implant placement. We do not want the drill to drift. The path drill is shaped like a square so that it does not slip even in sloped surfaces. The reason why I use a 7mm first is because of the double contact. If you use longer drill, the drill only touches the bone, not the barrel. Therefore, double contact concept I am using 7mm and 13mm in this case. That's how I used it. The final diameter was 11.5. 13mm path drill was just. Why didn't you use the path drill, Dr. Kim? When we place the implant, the one guide drill is tapered form. In the case of twist drill, cutting edge is only on the apex side. As I mentioned in the debate with Dr. Kim Gi-sung's lecture, side cutting is necessary, but in guided drill, side cutting drill is not possible. Therefore, path drill has been formed. The path drill has back taper on the palatal side. The strong hard bones are cut. The reason why I didn't use it because the patient has short root. In the case the patient has short root, if you do over preparation on the apex side and use a path drill, it may be unfavorable to get the primary stability. In the case of Dr. Son, the root was long and it was number 1. That's why path drill was used. But in my case, in order to get more stability on the apex side, I did not use the path drill. To give you more information, in one guide kit, the path drill itself is, as Dr. Kim has mentioned, it has micro back reverse tapping capability. Therefore, it can prevent the slipping. I think post-op X-ray are available. Can we see? So I'll show mine first.
Post-op panorama. So on the panorama, 5 bone techs are used. the implants are placed as planned. Number 23 looks a little bit deeper. But in order to get primary stability, I planned it to go a little bit deeper. On the CT, number 21 CT, as you can see, it was not pushed, and it is very well placed as planned. And the collagen graft is also observed. Number 23 is a little bit problematic. It is pushed a little bit, and I also felt it. So the EOS collagen is pushed, and if only 50% is ossified, it will be okay. So I was wondering whether I should make modification, but it is definitely pushed. So it is a little bit pushed. Dr. Kim, post-op panorama.
Dr. Kim? Implant has been placed and they determined the level in number 16. Sinus crystal approach has been done nicely. In number 14, hex tape transfer above 1 hex seems slightly less in, so I need to adjust it. This is the CT apex concavity can be observed. Pre-op, when I was doing briefing, tunneling technique to do submucosal graft, I focused on number 21. In socket preservation, I think primary stability was okay, and the apex side, so I thought it would be fine. This is number 22. And this is number 12. On the apex side, I think fortunately I did not slip because I thought it would be more closer to the apex, but I think this is a cortical bone and it has good muscle layer. Number 14, it looks good. Number 16, I did a crystal approach. I just did sinus lift. I think bone formation can be gained. So you don't need to do sinus bone graft when you just lift by 1 to 3 millimeter. And with a new surface, I think you'll be able to gain bone graft material. We'll entertain one more question to Dr. Kim Yong-jin. You mentioned it earlier during your surgery, but when there's a lot of soft tissue resorption, you used the granulation tissue to compensate for that. In type 3 socket, in chronic condition, chronic granulation tissue, if epithelium has been granulated, by using periodontal probe, you'd be able to get a good sense. The pocket would not be bad, and if the palatal wall is intact, you can use the gingiva in a general method. If you open flap, it will be lost, but if you do lingualized incision and make a slight vertical incision, the GBR process itself, the soft tissue condition is not good, but by using it as a dressing material, it serves its purpose. Therefore, if it can serve that purpose, the epithelialization and ossification can occur. Therefore, by using this, a simple preservation can be good. Did you use the number 15 blade, the 15C blade? I get these questions frequently. When you use it, I've heard it. I've never seen someone use it. Is it difficult to use clinically? I think it would have been. I think it was a good choice for this case because of time constraint. We'll now end the Q&A session. We will choose the best question related to past drill. How is it like using Lindemann drill? Stoli will be chosen as the best question. You've done a wonderful job. Thank you for the wonderful live surgery. You've done wonderful jobs. Thank you so much.
네, 라이브
Thank you, Dr. Son Young-hee and Dr. Kim Yong-jin, for the wonderful live surgery, and thank you for chairing the session, Dr. Kim Kyung-won. Now we will end the fourth session, and we will now look at the winners of log-in viewer event. A total of 300 people will win coffee coupon. Let's look at the winners. There are so many winners. Total of 300 people have won the coffee coupon. Please refer to the notice board and the demo site. Congratulations once again. The coffee coupon will be sent via the text. Now we will end the fourth session and have a brief break. In the first floor, there's the result of poster contest. It's a brief break, but please go to the bathroom and go to the first floor to look at the contest result of the posters. In the fifth session, we're going to have coffee coupon session and the lucky draw. Please stay with us and try your chance at winning prizes. During the break period, on the second floor in the product exhibit room, you'll be able to view different products. I look forward to your avid interest. Let's meet up again after 8 minutes.
Autobone Collector makes collecting autogenous bone easy and simple. All you need to do is drill once using the Autobone Collector to collect autogenous bone. With the Autobone Collector, you are capable of approaching up to 15 degrees of the left and the right. And it has a pointed tip that keeps the drill safe and steady, while also preventing it from slipping. Drill once and you're done. You can collect autogenous bone immediately with the Autobone Collector. Introducing the Trios 4, an intraoral scanner which scans and digitally replicates the oral cavity in 3 dimensions. The Trios 4 is extremely precise and offers fast scanning. It automatically eliminates unnecessary areas such as lips and cheeks during the scanning using the AI scanning function. Even the novice users can scan quick and easy. The Trios 4 is an integrated wired and wireless scanner. It is easily used wirelessly at large dental clinics. If the battery runs out, clinicians can continue using the Trios 4 by plugging in its power cable. The Trios 4 helps diagnose dental caries with its fluorescent scanning function. Also, the clinicians can track changes with dental caries over time. The Trios 4 can record patients' occlusal movement. The patient-specific motion function allows clinicians to record occlusion according to the movement of the patient's temporomandibular joint. Experience the Trios 4. It can be used in a variety of treatments. Introducing the OneCast Kit, the Digital Sinus Surgery Kit. If you use the OneCast Kit, you can digitally pre-plan the exact implant position and drill length required for the sinus surgery. Place the one guide template first, then use the drills with rounded apex together with the stopper in order to perform safe drilling. You can also perform hydraulic lifting and bone grafting while the template is still in the mouth. Try the OneCast Kit for safe and precise sinus surgery. Introducing the 1485 Kit, the implant surgery kit for mandibular posterior region. The 1485 kit is used for implant surgery in the mandibular posterior region with vertical bone resorption. The implant specification and position can be elaborated with digital planning. The surgeon can prevent damage to the inferior alveolar nerve even when the residual bone height is low, in case the surgeon places a one-guide template and performs drilling with the 1485 kit's round design drills. Also, the 1485 kit helps you to place from 4mm to 8.5mm short implants at proper depth and avoid any damage on inferior alveolar nerve. Try the 1485 kit when you need to perform a surgery in a mandibular posterior region. Introducing the S5T and S5L scaler, premium ultrasonic scalars made in Switzerland. The S5T scalars can be attached to the dental unit chair. A-tip, P-tip, and PS-tip. 3 tips are included, and therefore you may choose the appropriate tip depending on the patient's oral environment. The PS tip is especially long and thin, making painless and gentle scaling possible. Scaling with the S5L scaler is easy, since it has LED light for better visibility. Experience gentle and easy scaling with the premium Swiss scaler S5T and S5L.
안녕하세요. 다시 뵙습니다. 아나운서 이만을입니다. 저는 지금 임플란트 PM팀 임종민 대리와 함께
Hello, I'm announcer Im Ha-neul again. Im Jong-min from Implant PM team is with me at the material zone in the Osstem product exhibition hall. At a glance, it is filled with so many products. What are in the material zone? Mr. Lim? All the materials in this zone needed in dental treatment are displayed, including Osstem's representative GBR products, AOS, QOS, SureOS, impression materials, resin, and nighttime file. Oh, okay. We could have special experiences in each zone we have visited, so I get a feeling another experience is prepared first in the zone. Yes, you can discharge a high C plus in the material zone. Let me show you. Anybody can easily apply High Seal Plus to a tray. You can squeeze it and feel the soft discharging of it. High Seal Plus is has very short setting time. It takes about 2.5 minutes for curing, half of the time compared to other products which take 4 minutes. Short chair time is good for both dentists and patients. Osstem R&D Center Product Hall. We are already at medication zone the last visit. What we have here, various products from prescription drugs to little cargo spray, high functional premium toothpaste. You can experience chlorhexidine oral disinfectant with a good taste and fragrance, which does not discolor teeth. Can I try it? Sure. As you can see here, there's a difference of chlorhexidine, which is from Osstem. Can you guess? The viewers may not feel the difference, but there's a big difference in the fragrance. And I don't have to tell you which one is from fragrance, from Osstem. It is different. Very fresh taste and fragrance, very nice from Osstem. So I believe this can be used by users. They can really enjoy it. We looked around the product exhibition hall in Osstem R&D Center. Many people watching the broadcast may want to visit it. How can they do that? If you want to tour the product hall in Osstem, please contact our sales representatives or call the number on the screen that is displayed right now. So
아쉽게도 이만 인사를
this concludes the Osstem visit. Stay with the channel. Enjoy the rest of the Osstem meeting 2022 Seoul. I've been Haneul Im, announcer, and my name is Jongmin Lim. Thank you.
네, 오스템 미팅 2022 서울 이제 세션 5 다섯 번째 세션을 앞두고 있습니다. 다섯 번째 세션 시작하기에 앞서서 중요한 순서가 남아 있는데요. 바로 로그인 시청 이벤트입니다. 지금 바로 대놀 사이트에 로그인 하시고 팝업에 응모를 해 주시기 바랍니다. 그런데 여기서 끝이 아닙니다. 이번 세션의 첫 번째 강연이 끝난 후에 오늘의 하이라이트 통 큰 이벤트의 응모가 또 준비가 되어 있으니까요. 끝까지 함께 해주시기 바랍니다. 네, 그럼 이제 오스템 미팅 2022 서울의 마지막 세션을 이어가도록 하겠습니다. 마지막 세션은 해외 연자분들의 강연이 진행이 됩니다.
The final session is by the foreign speakers. The first is by Professor Marco Talerco from Italia and Dr. Peter Heaney from Czech. Let me introduce the chair of session 5, Professor Park Chang-ju of Hanyang University. Professor Park Chang-ju has graduated from Seoul National University School of Dentistry, and he has gone through training in Department of Oral Maxillofacial Surgery. He's a research scholar, Department of Periodontics at School of Dental Medicine, University of Pennsylvania. He is a professor and practicing surgeon at the Department of Oral Maxillofacial Surgery at College of Hanyang University. Greetings. I'm the chair. I'm Professor Chang-ju Park, College of Dentistry at Yonsei University. And Osstem Meeting 2022 is the most prominent dental event of the year, with no doubt. Now we are having the final session. The session's speaker is my friend, as well as an author of many researchers. Professor Marco Talerco is from Italy. Italy is not participating in Qatar World Cup. The title of the lecture is Digital Solutions to Begin Surgery with Final Prosthesis in Mind for a Perfect Smile. After a brief introduction video, we'll start with a lecture.
Professor Dr. Marco Talerco, my friend and co-worker. As the first special lecturer of the last session of 2022 Osstem Meeting Seoul, he is a world-renowned researcher, lecturer, and the current president of Osstem AIC Italy, and he's a real digital guy. As you know, he has just hosted Osstem Meeting Europe successfully. His topic today is Begin Surgery with the Final Prosthesis in Mind. After a short video intro, please welcome him with warm applause.
Dear Professor Park, thanks for the warm introduction. Fortunately, you translate because the first part, I didn't understand nothing. So thanks a lot. As Professor Park introduced me, I live in Rome. This is just some video from my city, the center, the St. Peter Basilica, and the Colosseum that was one of the 7 wonders in the world. I live in Rome in my clinic that is also a training center for Osstem, and I really want to take this option to really thanks Osstem OIC to invited me today. For me, it's a really pleasure, and I'm really honored to be part of the Osstem family. This is my clinic. I just want to show you because also in Europe we use Osstem K3 chair, and we took some live surgeries. Professor Park introduced the Congress that we held a few weeks ago, the European Congress in Rome, in my city, and this is the training center. My passion is digital technologies, and the topic of today is digital solution to begin the surgery with the final prosthesis in mind. And I really hope this topic is on the target of the Congress. Look on my slide, the future of digital dentistry, and I would like to give my contribution. As a researcher, I like to speak my lecture following 3 steps: science, common sense, and experience. About the science, don't worry, I will not bother you, just a few minutes to introduce some concept. The present of the digital solution, speaking about implants, are the guided surgery. In 2015, the European Academy of Osseointegration already stated that guided surgery must to be considered the gold standard in several approaches, such as minimal invasive integration with other digital technologies, aesthetic optimization, immediate loading. We see beautiful life surgeries, and complex anatomical cases. And this is the present. Why we love guided surgery? This is a very simple case, but is able to understand why we should use guided surgery. And because I use guided approach in 100% of my cases. This is a cases with the problem on the canine. We have a root resorption and endodontic problem also in the lateral incisor. In this case, I don't like immediate implants in this case because there is infection, so extraction, socket preservation with collagen material and xenograft, the same material that the surgeon showed before, with connective tissue on the top, Maryland bridge, and wait the healing, and then plan the guided surgery. I also want to contribute with some tip. The surgeon before speech about the double contact in the one guy kit, but the double contact is only for the drills. With this approach, reverse and then forwards, if you look, the motor is in the reverse approach, the implant can sit in the previously prepared site, and then we switch to the forward in order to have a bone contact with the implants. Of course, this is very important for 13, 11.5, 10 millimeter implants. But coming back to the main topic of this surgery, begin the surgery with the final prosthesis in mind. This is the final prosthesis. In the morning, we saw a lot of lecture about the digital solution. This is a T-link abutment, but if you look at the prosthesis, perfectly match with the planning. This is a canine position. This is a screw retainer restoration with link abutment and zirconia ceramic framework. So this is the present of the guided surgery. This is the follow-up, previous and after control, and X-ray endodontic treatment on the lateral, and implants placement in the canine position. So from a scientific point of view, I published several manuscripts with a couple of research groups. One from Professor Park, I'm really honored, and one from my research team in Europe. I just want to show you some manuscript. The conclusion from this randomized controlled trial are that with a guidance approach, we can expect less postoperative pain and swelling, of course, but most important is less marginal bone loss at the 5-year follow-up. And if we look at the 10-year follow-up, we can expect a very high implant survival rate, but mostly low prevalence of biological complications such as perimplantitis. I will show you, and also the previous surgeon and speakers show several cases with the one-guy kit. One-guy kit is unique because I have surgical template without metallic sleeves, and together with Professor Park and also Dr. Kim, congratulations again for the life surgery, we published several manuscripts, and we concluded that surgical template without metallic sleeves are more accurate than template with metallic sleeves. So this is the reason because we used. All of my patients it's been helpful for me to write this book. The title of the book is Diagnosis, Prosthetic-Driven Treatment Planning and Guided Implant Placement, the Key of the Success. And this is also the topic of today. But as I told you before, guided surgery is the present. I want to look at the future of the digital dentistry. So I want to level up speaking about the guided bone regeneration. The guided bone regeneration means CAD solution for predictable, prosthetically driven, guided bone regeneration and aesthetics. I don't know the microphone. Maybe okay. I can move there. Change side. Okay, thank you. So the computer-guided bone regeneration, in order to approach with a prosthetically driven surgery, also complex cases that need bone regeneration, in aesthetic or not. In the 2015, with my best friend Silvio Meloni, we published the first manuscript. Why guided bone regeneration, computer-guided bone regeneration? Because in all of this symposium, we heard the same concept. Not only the bone, but the pink aesthetic and the function of the keratinized tissue is most important. So the take-home message is begin the surgery with the final prosthesis in mind. Looking at the common sense, I want to show you some cases. This is the first, maybe it's the easier cases. It's class 4 according to the cave of the oval, anterior maxilla. Noemi had a car accident when she was 10 years old. For this case, I plan a customized titanium mesh and guided bone regeneration with autogenous bone and xenograft. Looking at the case, very high smile line. Most important, what Noemi asked to me, to have a bright smile. So I want to maintain the promise. This is the case. We see a bone defect. Fortunately, it's a contaminative defect. But due to the high smile line, we have some problem to resolve the aesthetics. If you look at the CBCT scan, the bone is, the vertical height is maintained, but we have only 4 millimeters to place an implant. Could be also enough with some technique, but we need to improve for aesthetic reasons. And as I told you before, I want to plan my bone augmentation procedure according to the prosthesis and according to the patient need. So this is a customized titanium mesh. It's very easy because I asked to my CAD design to copy and mirror, to copy and paste and mirror the shape of the contralateral bone. The same concept what you use to copy and mirror the shape of the contralateral tooth when we need to realize the prosthesis. And we publish with Professor Park this case and this technique with a customized titanium mesh. Look at the video. Unfortunately, we have not so much time. The concept is horizontal GBR. In Europe, we use a technique a little bit different, the technique that you saw before. The flap approach in the first upper left. In the upper right, you can see the implant position. Even if the implant is in the bone, we need bone augmentation. You can see right lower light, because we need to improve for aesthetic reason, to support the soft tissue. So we mixed 50% of autogenous bone and 50% of xenograft and put the membrane like you can see. 4 weeks later, 4 months later, we name this kind of GBR supported GBR because it's just to support the soft tissue. So we can reopen after 4 months because Initially, we have a good stability of the bone. So after 4 months, we just use PRF because the tissue of the patient was very good, and we reach our results to copy the shape of the contralateral area. Fully digital approach, digital scan abutment from Osstem, and the results from the soft tissues, but I really think that the most important is the implant position. We finished the case with a fully digital approach. And just to give you another tip, we use a zirconia abutment for the veneer and zirconia abutment bonded on a T-link with ceramic on the top for the implants. You can see the prototype model, but also the soft tissues. And we maintain the planning about 4 millimeters in order to give space to the dental technician to make a shape of the soft tissues perfect. And this is on the right of the patient, the implant, on the left, the veneer. And I can also show to you the surgery and a 3-year follow-up. And we reach the promise to the patient to give to her a bright smile. Looking at another case, another car accident, unfortunately, patient's a little bit older. In this case, we have the problem for 2 adjacent implants. But again, the philosophy is to start the surgery with the prosthesis in mind. So the workup is really, really important. After healing, we plan the surgery with the software. In this case, we just use the first drill approach because we need to check the vertical position according to the prosthesis, and we plan horizontal GBR with the same concept that I showed you before. So also for this case, just the first drill, the 2 implants from an occlusal point of view. But I want to stop a little bit here because it could be very easy to place the implant a little bit deeper and avoid big GBR. But the concept is I want to follow the prosthesis. I want to follow the cervical shape of my teeth. So if I want to reach a perfect smile, I need to believe in the workup, so the implant will be a little bit exposed, and classical horizontal GBR, as I showed you before, with xenograft and autogenous bone and collagen membrane was made. And I want to go, unfortunately, a bit quickly to the results. Even if we have a good keratinized tissue, we want to improve a little bit the soft tissues in order to have the papilla, because you know that the papilla between 2 implants is not easy. And we have several techniques. I want to show you this, that is the closed technique, classical, and then I will show you an open technique to improve the quality and not the quantity. With this technique, we improve the quantity of the soft tissue between the 2 implants and the temporary. We wait for the maturation, the radiographs of the 2 implants. And here you can see the false papilla between the 2 implants, also from an occlusal point of view. Of course, it's not perfect like the contralateral, but I want to remember you that we leave the implants a little bit out of the bone. If we place the implant deeper, 1 to 2 millimeters, the papilla go deeper, because Tarnow demonstrated, and then other authors, that we can maximum reach a mean of 4.5 millimeters of the papilla between 2 implants. Again, the definitive prosthesis in the patient mouth, the radiograft, and again, we need to copy the workup. This is already our starting point. We have another 2 cases, a little bit more advanced, because there are vertical defects, class 5 according to the Kaywood oval. One on the posterior mandible and the last in the anterior maxilla. Here the promise is different because the patient doesn't want bright smile, he wants to hit. So this is a complex case I treated with some friend of mine, prosthodontist and perio, In this case, my colleagues asked me to treat the lower left sextant. So you can see the defect, vertical defect here in the middle area. The treatment plan started with initial periodontal therapy, implant placement, and GBR, and perioprosthesis rehabilitation. So here I want to show you, just in a few seconds, the planning. The planning is complex because we have tilted implants buccally, lingually, close to the nerve, and this is just in the normal position. But I want to focus here. Prosthetically driven approach. In the morning, the authors speak a lot about, also in the discussion section, very interesting, about the screw retainer restoration. With a guided approach, even if we need GBR, we can plan GBR in according to the prosthesis, and we can deliver screw retainer prosthesis. I'm so sorry for this, but in my hands, 100% of my prosthesis is screw retained, and in Europe, maybe 95% of the restoration is screw retained. This is the reasons because we reach to plan in advance because we want to deliver screw retainer restoration. Looking at the video is very quickly, but another tip I think that you know, it's possible to prepare close to the nerve using the one casket also in the lower, because we can go close to the nerve with a non-invasive drill. So in this case, you saw by the planning, that is a very tricky case, but the last 2 millimeters of the implant site have been prepared with the one cast drill. Smart build osmirdel membrane, the same 50% of autogenous bone, 50% of xenograft, and this is the post-op radiograph, also for a three-dimensional point of view. And here you can see a comparison between the pre and post results. Horizontal GBR in the last implant and 4.4 millimeter of vertical gain in the middle implants. But again, I want to focalize on the prosthetical approach. For this case, I convert the internal connection with multi-abutments, but I used 2 straight abutments and just one 70-degree tilted, just to save not the buccally position, but because the dental technician want to move mesially the emergence, as planned in the walks-up. If you look here, this is the temporary restoration, and this is the metal framework. Posterior is a long span metal framework, but again, a screw retainer. The screw holes are perfectly in the occlusal surface of the implants. This is the metal ceramic restoration, X-ray that show the bone. And here I can show to you before and after, but also the 3, and recently, immediately before I came here, the 4-year follow-up, also from a prosthetic point of view, that show the stability of the regenerated bone. This is my last case, class 6, because he's a very atrophic patient, anterior maxilla, vertical and horizontal defect. Beatrice was a very, very perfect patient, but she has to me that she won the teeth that she had before the accident. And this is a removable prosthesis that is my starting point, because Beatrice told to me, I also like the support of my lip. So the prosthesis is my starting point. Look the thickness of the prosthesis. We need to improve the bone in order to give to her the same support without the prosthesis. So I scan with the intraoral scanner the prosthesis, and we are able to pre-plan the amount of bone graft. If you look here, this is the amount of bone graft that we need, that incompatible with a one-stage approach. So in this case, we need more surgeries, 2-staged approach. And Beatrice told to me, I want my teeth when I was young, but I don't remember, I don't know the teeth. So I take inspiration with her mother. I scan the teeth of her mother. This concept was published by Dr. Kochman several years ago. So we can scan with an intraoral scanner the teeth of her mother. We can create personal libraries, and we can move the shape of the teeth of the mother on her daughter in order to have a reference for the shape present in the family. The third step is to calculate the perfect position of the final prosthesis, because the axis of the implant, the position, the dipping of the implants are related to the prosthesis. So I want 4 millimeters, as I showed you before, between the cervical part of my teeth and the implants. And I want to deliver a screw retainer restoration. As you can see, we need to improve the bone before and place the implant later. But in the software, we can see everything. So looking at the surgery, just some spot vertical defect, more than 7-8 millimeters of vertical defect. The same concept, the same flap, the same procedure, but in this case, we use a very thick pericardium membrane, or alternative could be not resorbable membrane, but titanium mesh, for example, need to stay 2 millimeters far away from the adjacent teeth, so we prefer resorbable pericardium thick membrane. And this is the first surgery performed by Beatrice. After 7 months, second surgery, implant placement, and supported GBR. Why? Because even if the bone is good, it's bloating, we place the implant are not exposed, but we promise to Beatrice to support the lip. So after implant placement, we plan supported GBR. Supported GBR could be made with 100% of xenograft in this case, because we don't need to put the bone around the implants. So again, one guide kit, TS3 implants, reverse and forward approach. In case of regenerated bone, the torque was very low, about 10-15 millimeters, because the bone is not yet mature, but we don't plan immediate loading. So the implants are covered by the bone, but we need to improve a little bit more in order to reach the aesthetic results and to maintain our promise. So collagen membrane, in this case normal membrane, only xenograft in order to improve the thickness of the regenerated bone, and a first connective tissue graft on the top. As I told you before, connective tissue graft on the top is to improve the thickness of the tissues. There are some techniques, some speakers already stated about this. In this case, I prefer desepitalization technique, and to fix Eastern urban name sashimi, maybe because it's white and recall the sushi food. This is connective tissue graft on the top, fixed with internal suture. But you already saw 2 live surgeries, so I can skip a little bit. As I told you before, we don't need only of the quantity of the soft tissue, but we also need of the quality of the soft tissue. So the second technique that I want to show you is to improve the keratinized tissues. This technique, the name is strip technique. Also, there are several literature that stated the importance of the keratinized tissue to avoid bone resorption. And I had a personal consideration. Keratinized tissues is most important. It's most important today with the surfaces of the implants, of the modern implants, but is particularly important in case of regenerated bone that have a quality, a different quality compared with the native bone. So this technique is named open approach, strip technique. The concept is to put some strips of epithelium around the area that was left open so that the healing could be from the top to the crest. From a genetic point of view, we have cells that we call the epithelium because we want to improve the keratinized tissue. Because Beatrice is very young and the implant must to remain in her mouth for a lot of years. So, and also because, if you remember, the starting point was very complex. So we needed to improve the bone, and now we want to make the bone secure. The flap is open, connective tissue is exposed, strip of epithelium on the border, so that inside the garden, Eastern urban names garden technique, can heal for second intention. And we put a membrane on the top just to protect the healing phase. And this is the third surgeries. Bone augmentation, vertical and horizontal, implant placement and supported GBR with the first connective tissue graft, and the third surgery to increase the amount of keratinized tissue. Beatrice, as I told you before, is very nice. With a removable temporary restoration, she graduated 110 cum laude in chemical engineering. Why I told you this one? Because to reach good results is most important, maybe the surgeon, the materials, but also the patient must be really collaborated. And Beatrice was really fantastic. See the healing, we increase the amount of keratinized tissue, and we are ready to reopen the implants. We started from this to this, reopening with customized healing abutment, temporary restoration, healing the false papilla. With the fixed temporary restoration, Beatrice also took a silver medal in swimming. As I told you before, he has fantastic patients. This is the results, and we reach with all of this plan and surgery to maintain, also to improve a little bit the aesthetic lines. Or aesthetic lines mean support for the lip. On the left with the temporary prosthesis, on the right with the fixed prosthesis on implants. So we move to the final restoration. We copy the shape of the mother here. Maybe the case is not perfect, but we have false papilla. The anatomy of the teeth is quite good. The tissues around the implants is good. But most of all, Beatrice is completely happy. This is some emotional pictures. Comparing to the before and comparing with her mother. So just 1 minute to conclude this short and quick presentation. I'm so sorry for this. The conclusion is from two sides. The first is a personal conclusion. I'm really proud to feel part of the Osstem OIC community. And my dream is that become the biggest scientific community in the world. From the lecture point of view, the conclusion is the beginning. Begin the surgery with the final prosthesis in mind. As I told you before, the key of the success of the guided surgery is the prosthetic plan. Place the implants according to the prosthetic plan. So we move for the future of the digital dentistry the same concept on the guided bone regeneration, to pre-plan the amount of bone we need in order to try to reach the perfect aesthetic results, but most of all, the long-term results of our implants. I really want to thank my staff. Fortunately, I work with all female. I'm really happy for this. This is my wife and all of my staff. This is the gala dinner of the Osstem IOSN meeting in Europe that has been held in Rome the end of October. The gala dinner was fantastic, and I again take this chance to thanks again, Osstem Europe, to always supported me and also to organize this fantastic event. My time is finished, but I have just 15 seconds. Recently, I read an article, and as Professor Park said, the Osstem ISM meeting in Europe was a tribute for implantologists, and I'm really, really happy for this. I also want to thank Dr. Chung and Dr. Chung, sorry for my pronunciation, maybe Professor Park can, can name well, because take part together with me in a nice roundtable. The take-home message of the roundtable is the same that I want to show you before. Osstem OIC together has not limits. So thank you so much, and time for Q&A.
Thank you very much for your excellent lecture. And I'm very happy to see your lecture finally in the end of COVID-19 worldwide pandemic. And anyone who has a question to his lecture from the floor?
Don't be shy.
예, 강의 너무나 감사드리고요. 간단한 건데 전치부에서는 심리가 중요한데 그 엠브레저브의 파필라를 살리기 위해서 특별히 사용하시는 방법이 있으신지 여쭤보고 싶습니다.
Now, Professor Park will translate, maybe.
Yeah, his question is to save and reconstruct the interdental or inter-implant papilla.
Yeah.
You used the connective tissue graft, right?
You
used connective tissue
Yeah.
graft from palate.
Yeah.
So his question is about
No,
your own tip or technical tip about using connective tissue graft to reconstruct the inter-implant papilla.
thank you for the question, because allow me to explain. In the first case that I show, is a small part of connective tissue was arrested from tuberosity, because the tuberosity is the first choice to reconstruct the papilla, because it grows during time. In the last case, I used connective tissue graft from the mid of the palatal because I needed a big amount of connective tissue graft. It was not possible between the tuberosity. Finally, the patient, Beatrice, was satisfied. But if you need to reconstruct more, for the last case, you should need a first connective tissue graft during implant placement, as I performed. Then improve the keratinized tissues as performed. And if you want more, the third connective tissue graft from the palatal, from the tuberosity. So just to reassume, to reconstruct the papilla, tuberosity is the first choice. And I teach it on my skin that connective tissue graft are never enough. So it's very common, if you want to reach aesthetic results, to perform 2 or 3 soft tissues augmentation. Usually 1 to improve the thickness, 1 to improve the quality, the keratinized tissues. And as I told you before, the first choice for the papilla should be the tuberosity. In the last case, I didn't use the tuberosity because I needed a big amount. Maybe it could be another procedure. Maybe she did. You can summarize.
원장님, 저기 보통은 맥실러리 튜베로시티에서 띄는데 보다 두껍게 띄는 경우에는 팔레이트에서 띈다고 하셨고요. 두 번째는 이와 같이 임플란트를 심어놓고 파필라를 재건하기 위해서 소프트 티슈 또는 커넥티브 티슈 그랩을 하는 경우도 있지만 더 많이 하고 싶으면 수술, 임플란트를 심기 전에 미리 올려놓는 경우도 많다고 해요. 그리고 세 번째는 케라티나이즈드 진주발을 리컨하기 위해서는 2번 그리고 3번의 소프트 티슈 오그멘테이션 프로시저를 하는 것을 일상적이라고 생각하신다고 말씀하셨어요. 혹시 더 필요하신 거 있으세요?
It's okay. Thank you, Professor.
If you have no question from the floor, I'm going to pick up one question online from live chat in Korean. So 제가 읽어보도록 하겠습니다. 스마일 디자인 과정이 매우 독특하다고 합니다. 라이브러리를 가족에서 가져왔잖아요. 그런 것이 어떻게 되는지 좀 더 자세히 설명해 줬으면 좋겠다는 그러한 질문이 있어서요. 제가 영어로 번역하도록 하겠습니다. Professor Tellerico, you showed in your lecture the smile design from library from the patient's family. But if the patient wants smile design from library of famous actor or celebrated, there will be very complicated requests from the patient. So do you have any protocol to imitate the smile design from the library? This is the question.
I have not any experience with famous people because except you, I didn't know any VIP person. But Dr. Kochman introduced this concept with the name of Smile Donator. As a researcher, I don't like Smile Donator because it's most from a marketing point of view. But the protocol is very simple because fortunately I have a perfect staff team in my practice with also some CAD designer. But it's just needed to take a scan with the software to make the outline of the tooth, to segment tooth by tooth and store it in a computer. The software make this procedure very easy. About the VIP person, the celebrity, it's possible, but the celebrity make to donate a scan impression. But it's very easy because the protocol is to segment the tooth one by one and store. Then it's possible to modify the shape starting from the original one.
선생님, 사실 카우치만이라는 의사가 제안한 스마일 도네이터라는 컨셉이라고 합니다. 하지만 문제는 의외로 쉽다고 하는데요. 치아를 각각 세그멘트해서 저장한 다음에 위치와 모양을 모디파이 하는 것은 디지털적으로 그렇게 어려운 일이 아니라고 합니다. 다만 이제 이것은 제 생각인데요. 스마일 도네이터에 따른 스마일 디자인을 하다 보면 정말 대량의 GBR이 필요한 경우가 있잖아요. 그런 경우에는 결국 타이타늄 메쉬 같은 것을 사용할 수밖에 없고요. 수술이 다소 복잡해질 수 있겠다는 생각은 들어서 이걸로 일단 이 온라인 질문에 대한 정리는 하려고 합니다. And this, I want the last person to have question to his lecture from the floor.
비용하는 부담이 얼마나 될까요?
I'm a little bit scared.
Professor Tellerico, yeah, his question is about the medical fee because to imitate the smile design or smile donation, there often requires a lot of or large amount of GVR. So how much usually do the Italian patients pay for implants and GVR and other soft tissue augmentation procedures?
Okay, regarding the Smile Donator, in this case, it's free of charge because it's the mother. Easy. and I will not perform smile donator for a VIP for money. About the GBR, thanks for the question, because in my tour here in Seoul, I am really happy, and I realized that Osstem is the brand #1 in the world, because maybe first of all is the best ratio between quality and efficacy, and this is the normality. But I also think that, or better, I don't want to speak about the cost, I want to speak about the value. So, just to give a response, there are some situations that it's possible to find a compromise. But there are the other situations that the compromise is a little bit more hard and depends on the request of the patients. For example, the last case maybe is the most expensive. The mother told to me, I will do everything for my daughter. Don't think that it is very, very, very expensive, because always this case is less expensive than you think. But I teach in my skin that to maintain the promise, maybe I need to go a little bit more here, to maintain the initial promise to the patients sometimes is not easy, and depending by the initial point. So I completely agree that GBR is a more expensive technique comparing with thank you. I completely agree. Doesn't work the same. Is working? Yes. I completely agree that GBR are more expensive comparing with, for example, narrow implants, for example, a dentulous ridge expansion, but there are some particular indications. And regarding the 3 procedure, implant placement, the same price. GBR is one more cost, but digital technologies are not so expensive as is possible to think, because customized membrane, maybe the cost is quite similar to a conventional membrane. Sometimes connective tissue graft is not a cost in Italy because it's performed together with another cost. Connective tissue is free of charge. So I completely agree that the cost is higher comparing to other procedures. But the indication are for this kind of therapy, and I also want to speak about the value. So in my practice, I noted in the last year that even if it's more expensive, I improve the number of GBR procedures in my clinic, because improve the number of complex cases. But in order to reach medium long-term results and to reach aesthetic results, I think is mandatory. So it's most important to select the patients. As I told you before, the patient is most important. Not only because maybe need more surgeries and need to have a big collaboration, also because the procedure is a bit expensive. But believe in me, these procedures are not only for rich people. Beatrice is not a rich people. Are for people that understand the need of some procedure, more than one material, etc. So this is the real concept. Honestly, digital technologies doesn't improve the cost. Most of the cost is the number of procedures and the materials. Digital technologies, maybe, I'm not sure, could a little bit reduced, but I'm not sure. But of course, doesn't improve the cost.
원장님, 구체적인 금액은 언급하지 않으셨지만 요는 환자에게 필요한 술식은 어떻게든 하려고 하고 환자의 경제 상황에 따라 조금씩 조정한다는 그런 원칙을 해주셨고요. 원칙을 말씀해 주셨고 디지털은 특별히 따로 페이를 받지 않는 편이시고 특히 오스템 처음에 말씀하신 것처럼 오스템 하이오센 제품들이 비용에 비해서 굉장히 좋은 효과들이 있기 때문에 잘 사용하고 있다고 말씀하셨습니다. 괜찮으세요? Yes. Now I'd like to close the first part of the last session. Please, one more round of big applause to Professor Tellerico.
네, 열정적인 강연
Please give another round of warm applause to Professor Marco Tellerico and the chair, Professor Park Chang-ju.
네, 그럼 지금부터는
There's only the final lecture left. We're going to announce the winners of Coffee Coupon event, which was held with the start of the final session. Please take a look.
네, 정말 많은 분들이
Congratulations again.
당첨이 되셨습니다. 당첨되신
A lot of
분들
people
지금으로
have won great
자세한
prizes.
결과는
Congratulations. You can check out the
공지사항
results
확인하실
via
수
the
있습니다.
notice board on the dental site.
문자로 커피 쿠폰을
Texts will be sent
또 있습니다. 모든
for delivery
분들께서
of the
기다리고
prizes.
오늘
The
회의가
highlight event of
여러분의
today,
아쉬운 마음을 달래는
there is a grand event
지금 바로
where lucky draw will be held.
세 분께는
3 people will
갤럭시
receive
버스
Galaxy Buds
두 분께는
2
갤럭시
Pro,
워치 1
and 2 people will receive
갤럭시
Galaxy
Z
Watch 5. 1 person will receive Galaxy Z Flip 4. Please try your chances at winning these amazing prizes. The winner will be announced after all sessions have been closed. Next, I would like to introduce the next chair, Professor Lee Boo-gyu of Seoul Asan Hospital. Please welcome him with a warm round of applause. He has graduated from College of Dentistry at Seoul National University. He has been the Academic of Affairs at Korean Dental Association, professor at Asan Medical Center, College of Medicine, University of Ulsan. He's president-elect, Association of AAOMS. Greetings. I am Professor Lee Boo-gyu, chair of this session. I would like to thank the audience for being with us despite today being Sunday. I hope you gain a lot from this experience. This is the final lecture. The lecture is going to be provided by Dr. Peter Heine from Czech. The title is Digital Aesthetics from Plan to Articulation. Please welcome the doctor with a warm round of applause.
Hello everybody. My name is Peter and I came from Prague, but I will not show you the Prague because I know that you know it. I saw a lot of Korean couples making wedding photos on our Charles Bridge, so I know it was in some movie in here, but you will see it at the end. Are you tired? Let's wake you up. Let's wake you up. You know what, I'm in a digital dentistry since 2005, when I started to scan, when I started to leave the analog way. And first time I saw the CAD cam when I was 17. I was in Sweden, and I saw the CAD cam in time when we didn't have optical impressions. We didn't have scanners. It was a manual scanner. And in that time, as a dental technician, I was looking at it like, okay, this is the future that maybe I will never see in my lab or my office. But just in a few years, everything has changed. Now we have everything digital. We can digitize each step of dentistry. But all the equipment, you saw I have a lot of equipment, all the equipment that we use needs to be user-friendly. It needs to be easy to use. It needs to be everyday usable. If it's something that is too difficult, usually you see those colleagues that are not that familiar with that and they don't use it. So throughout the digital dentistry, we have some advantages, okay? We have some numberized information so we can objectivize all those information. We can send everything everywhere. We can copy that. We can repeat it. We can do the same restorations even before the patient is coming. You saw a lot of those things. I have to thank to Osstem to be a part of this because I saw so many amazing lectures. You know, every time I'm on some congress, I ask myself, did you see something new? And this time I can say, yeah, a lot of. And I think that I don't need to explain each part of this digital dentistry because you saw a lot of it. But I have to tell you that what changed my way of praxis was that now I do full mouth reconstructions in one day. I do a lot of restorations. My maximum is 158 ceramic restorations a week and 4,500 veneers a year. So I have a lot of a volume of data, so a lot of studies, and we can really compare, you know, how the materials work and how the technology works. In average, when I calculate the time for one restoration in a year, if I calculate all the restorations, I know that it's 24 minutes. So if I know that the patient is coming for 10 restorations, I know that I will need 5 hours and still I will have a little break for that. So everything got more precise, everything got more automatic. Because I have 6 4-axis milling units, I can mill 6 units every 10 minutes. So it's something that no lab can offer me. And this is what I like, because in the heart, I'm still the dental technician, more than a dentist. So yes, I'm a user of Osstem implants, but I'm sure I'm not the one who can talk about the surgery today, because I saw those gods. And I have to thank again to Marco, you know, to show us, you know, the premium implantology. Impressions have changed, but still, if you compare the preciseness of analog, silicone, and digital impression, you still see some disadvantages or inaccuracies. And we are still testing new scanners. Next Friday, I will be doing a huge test for the new 3Shape 5. And I have to tell you, because there are many questions about the scanners, each of those intraoral scanners has some problem. But the problem is not the hardware. The problem is usually in the software or in our hand. Still, there is a human being behind the scanner, and that's a problem. So the strategy, how we use the scanner, is you know, very important for the preciseness. So we can see a lot of differences with each scanner. We can do good scans or bad scans. But really, I see a good future because I even tested a scanner that is still not on the market in Europe. I don't know if it's in Asia, but it is a scanner that, you know, intraoral scanner that is more precise than the lab scanners. So there is a future of completely precise scan. But we still see some disadvantages. So this is one, let's say, thing we need to think about is nothing from the digital world is completely strictly precise. Then, why we need to have the intraoral scan? Because today is very common. Please raise your hand, who of you has an intraoral scanner? Great. I remember when I started to lecture in that time for Sirona, and then for 3Shape, I was many times on the congresses where only 2, 3 hands were raised up. So then, of course, there is you know, the community of users It didn't work. At the beginning, for example, when I started in 2005, I was the only one in Czech Republic. There was no one in Slovakia. There were 3 in Poland. There was no one in Estonia, no one in Lithuania, and all those countries around us. So there was nobody to talk about it. Today, we have an internet, we have social media, we have a lot of options, a lot of scanners, and we can communicate all together. We use the intraoral scanners for many things. And my dream is to have the intraoral scanner by each dental unit, because each dental hygienist or each assistant should know how to make the scan. Because in the intraoral scan, we can get more information than just the 3D data. So we have a lot of options how to use the intraoral scanners, for what we use the intraoral scanners. Today we do, normally as a general practitioners, we do orthodontic treatment. We discussed it with your chairman. Yeah, this is the future. Everybody will do the orthodontic treatment because of digital dentistry. We can do the scans even with the telephone. This is, thank you. This is a scan with a very old iPhone X. Today, it's much, 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 much better. So in the future, maybe we will not need even intraoral scanners. Who knows? There were the face scans already mentioned in those lectures before. It's still improving. We can do a lot of those 3D scans directly from our cell phones. And yes, sometimes we even use it for some planning. So, you know, each year we have more options how to use our digital equipment. If we have intraoral scan, it doesn't mean we can do only communication with the lab. The way we know, like I do the scan and the lab will do the work. No. We can have a dental designer in the lab, send there the data, but the data can come back to the office. So the final or temporary restorations can be done immediately by the 3D printer or some milling unit in a dental office. And we can communicate with the lab like this way, so even the final restorations should not be all the time done in the lab. It should be done in the clinic by the dental chair. So it depends, you know, what is the most efficient workflow for you, because now we have a lot of options. It's not just one way. Thanks to the digital dentistry, a lot of materials appeared. We have more options of treatments in prosthetic point of view. But when we talk about digital aesthetic, can we even combine those two words? You've heard about copying of some shapes of artists, for example. Why not? It's possible. Actually, we don't do that because most of our famous stars we have, like my patients, they don't have a pretty, you know, teeth. But the main thing is that if we want to talk about the aesthetics, we need to know the basic rules of aesthetics. We need to have a lot of knowledge. We need to have a lot of skills. We need to have a lot of experiences. Because if somebody says, I know the morphology of the tooth, it's wrong. It's the lifetime problem. We need to learn from each case, from each patient. In a past time, every dentist using, so which microphone now for? Thank you. Okay, thank you. Each dentist using some metal-free material thought that he's doing aesthetic restorations. And this is the result. Yeah, we had not metal crowns, but some crowns covered with something. But the basic thing is to learn how the tooth should look like. Then we can talk about the aesthetics, and then we can say we know how to prep or how to place the implant. That's what Marco was talking about. We need to know the future shape of the tooth and the position of the tooth to be able to plan. And if we are not able to imagine that, we need wax-ups, we need mock-ups, we need to plan. If we know how to do it, if we know the future shape, maybe we can make it in a shorter time without all those helpful things. but it needs a lot of time. When I started, I spent every weekend making wax-ups. I did all the wax-ups for my patients, but I spent all the weekends, at least for 2-3 years. And yes, then after those 3 years, I slowly stopped doing it. We can choose even the color digitally. There are many options, but it should not be expensive. We can do it very cheap. We just need some camera. Now everybody has a very well-known cameras in Samsung phones or anywhere else. It's excellent, so you don't need even those huge cameras. And if we know how to use it, if we know how to use the lights and how to use the filters, we can record the pictures that well that we can read the shade from the picture. I saw in some of those lectures today there was a ELAP, you know ELAP for the shade analyzing, but we can use even simpler way. Just make a picture with a shade guide and use some graphic software or even PowerPoint or Keynote, and we can just match the piece of a shade guide to match to the teeth. And when you do that, you will realize that not any tooth is same color like the other. And we need to learn that in today's aesthetic prosthetics, we have not even shades. We have a lot of options. We have many translucencies. We have many other effects in new materials. So it's not about a shade all the time. Yes, shade is one information, but we need to know something about the value, about the translucency, about opalescence and other effects. But there is even easier way with some equipment that does it for us. When we talk about the planning, when you say planning today, it means digital smile design. Okay, it's the way we did because it was very modern. But sometimes you don't have a time, and sometimes it's too expensive, regarding the time. So when the patient asks just, okay, I want new teeth, how it will look like, we can just use some simple softwares. Doesn't matter if it will be paid Photoshop or if it will be some cheaper version. We can do it very fast. And that's the point. If the patient during the consultation asks for some visualization, it needs to be immediately done. Not that I will do the picture and then I will spend the time with that instead of being with my family or with my hobbies or whatever. So it should be done in a few minutes. And we have a lot of options. Yes, this is made in Photoshop. Instead of Photoshop, I sometimes use GIMP, which is even on a portable version. But we have also another options, classical digital smile design, when you can send the scans, you can send pictures to the digital smile design center, and it can be done for you, even with the models, with the mock-up, with everything, but it's expensive. It's fine, it's beautiful to have it, but not for each client. Sometimes we need to really to treat the clients that way that we will save them the money and save them the time. So yes, this is one of those options, but we have even faster. Do you know AvoSmile? It's available for the iPad or iPhone. You can set up the teeth, about the shape, shade, size, whatever, and then the patient can look at himself in the selfie camera immediately. So even by the movement, can see the new teeth. And that's it. Immediate motivational mock-up, let's say. And if we compare all those types, and then we talk with the client, usually we finish with completely different shape than it was planned. That's the other thing. We need to understand that what we see in the plan is not the same what the patient sees. They want a huge white smile, that's it. But they don't see those differences in a macrostructure, microstructure of the teeth and other things. So it's more just to communicate and to get the information. What I really like is the mock-up, the printed mock-up. So if the patient has worn teeth like this one, and comes for the consultation, we can do just the scan and say, okay, we can set up another appointment, maybe for the final treatment. Until that final treatment, we can prepare several types of shapes. And I like this. It's easy, it's fast, and doesn't matter if I will print 6 or 40 teeth, it will be in the printer at the same time. So we can choose, different kind of libraries or record our own libraries. We can even buy libraries from other colleagues. And it can be prepared for the patient without any other losing of time. So it will take only that time of designing this. And you see how quickly we are switching in between the shapes. And of course, we do even the articulation. So then finally, of course that the patient is surprised, because if the patient will come and you will offer to him several types of smiles, immediately, it changes his life immediately, so he trusts you. Yeah, it's a lawyer, very famous lawyer, very stressed lawyer, as you see. But happy, and this is just the mock-up, without any prep. We just try that. And this is that patient where we need to be effective because he asked, okay, I have a time only on a Friday evening. So on a Friday evening, he will come and you will start with the prep. There's no time for another visit. Simple cases. I like those copyings, and this is where I explain even to dental technicians how to choose the proper material for creation of such restorations. Because with the CAD/CAM, we can easily copy the shape. So it's done. It doesn't take too much time. But now, thanks to CAD/CAM, we can measure the thickness of the material, so we can exactly choose the proper translucency of the material, because now we have very dark tooth prepared for the thick crown and very bright tooth prepared for the very thin veneer. And if you will choose completely the same material, you need to choose different cement. And you have to play with that to achieve the final aesthetics. But even this is just monolithic, no layering, it's just shading, glazing. It's enough. Of course it's not perfect, but this, there is no patient who can see that. You can see that, but not the patient. And what is more important, 1 hour, 47 minutes. The whole treatment, from coming of the patient with a problem to payment. If you ask how much it costs, it depends which country. I like this movie, do you know it? We lost the sound maybe. Can you check it, please? This is the movie where it's a science fiction, but they paid with their own time for everything. And if they didn't earn enough, they died. But truth is that today we are paying with our time. If you will calculate, what money you have to spend for something, I usually see behind that money the time I need to spend in my office. So then I think, isn't it better to rather to go somewhere and enjoy the life? Because we are paying with our time. So the time for me is the most expensive part of the whole calculation of each type of treatment. Time, not the material, not the equipment, but the time. We talked about the orthodontic treatment. Here is a patient who came. Here is a milk canine, permanent canine, second incisor missing. What to do with that? She came because she expected immediately to be treated with veneers. Yes, I can do that, but the preparation will be cruel. We did the scan and we planned the fixed orthodontic system, which is simplified just to the front region, and we treated this lady just in 4 months. After 4 months, she came, we just removed, we put it in the retainer and did the preparation without extraction of that milk tooth. The root wasn't that long, but it was working. There was no problem. So we explained, okay, we can change the shape of the tooth. We will need to touch the gingiva also. And in time, this tooth will be extracted. We will put the implant, but we will treat just that one tooth. In time, you will have a problem. This is done already 8 years ago, and it works. So why to do that, what we call the over-treatment? It can be done very quickly and easily. And of course, quicker you do that, cheaper it can be. Another case, this one was very cheap, because when we saw this guy, and he was a student in that time, we realized, okay, this is a nice case where we can present all the digital plans and mock-ups and everything. And we offered him a big discount, huge discount, if he will be, available for all those pictures. So we have a lot of pictures by a checkup. And this was the first visit. This was the first time I saw him. He had some braces for 5 years. He didn't know why, but he had it. So we removed this and made a scan, just to have a chance, to plan something, to check everything. We did the scan with already prepared position of the bite. So we designed the new teeth according to the wished shape and size of the teeth. So this was the initial situation at the beginning. This is the scan and the plan in the 3D. And then we printed and milled different kind of mock-ups. And finally, he came and we immediately done everything. We just placed that white mock-up. I made it white. You know why? Because I wanted to push him to normal colors. I wanted to ask him, do you like it? No, it's too white. Okay, thank you. Because otherwise, everybody answers, if I will show B1 shade guide, they say, oh, it's yellow. So most of the teeth we do now is bleach 2, bleach 3. So in that time, I thought, okay, let's do it white. So he will rather step backward to the normal shades. So during one visit, all the teeth, 12 in the upper and 14 in the lower were done. And again, we had a scan of the mock-up inside of the mouth, then the preparation. We tried, different designs. We milled it with different materials because we wanted to show, all those options. I don't use zirconia for single crowns. I love zirconia, I use it, but I don't use it for single crowns. And I don't even use zirconia for abutments. I use lithium disilicate. You know why? Because it works, and I have a final aesthetics from the bone level. So I can support the gingiva with colored ceramic, with fluorescency, and with proper dent in color. So this is the final restoration. Everybody asks, and it doesn't fall? No. Adhesive dentistry works if we do it properly. Of course, if I say 1 day, this means really the whole day. There is no break for lunch. Actually, it's not only a day. You are finishing in the evening or night. So yeah, it's a whole day of treatment. But this is what I like, because you can focus just on one case, on one patient, and you can do it even more comfortable for the patient. And what's nice by this patient that we can see him after years. So we can see the movement of the teeth. We can see how the translucency changed a little, but also how papillas growth. So there were no defected papillas. There was just missing tooth structure, and we changed it with ceramics. And in 5 years, it growed this way. So from my point of view, we did it wrong, because there was not enough space in the interdental places. Next time, when you see this, you do the morphology of the contacts a little bit different.
to leave more space for that. Okay, but we have to articulate such cases. And believe me, articulation paper doesn't work. In 80% of articulation with the paper, it's wrong. And 20% is a good luck. So now we are digitizing even those contacts. We can measure those pressures. We can see the movements during the articulation, and we can treat such cases. This is a simple case because I did already the articulation in the software when we were doing the morphology. But usually where is the problem, and that's why I'm telling it here, is a combination of teeth and implants. Because everything in the mouth has some movement. Bone is moving, joint is moving, tooth is moving, not the implant. Actually, even the implant is moving a little. It's about 10 microns. So we can divide, let's say, the pressure separately on normal teeth or on the implants, and we have to see it differently. Today there is an option to import the STL data to that scanner, so we can see even exactly where are those contacts on the teeth, not only in that graph. And I will show you one of my very old cases just to see what happens if we just do the crowns on implants and we believe to the patient that everything is okay. This patient was in my office just because of the veneers after some orthodontic treatment, okay? And then I visited the orthodontist because of another client, and I saw this lady sitting in the waiting room. And I asked her, "Are you okay? Is everything fine?" And she told me, "Yes, everything's fine, but sometimes, especially in the morning when I wake up, I have a problem. I feel like there is something, some pressure in front." And when we checked with the paper, it was there, yeah. And now I can just repolish that contact and she will say, "Yeah, it's better." And I will be happy, she will be happy, but the problem is not solved. Because instead of that, we took the T-scan and we measured this, and this is a problem. 70% of contacts is on the right side, and we have one overloaded tooth. 31% is just on this contact. And where is it? Crown and implant. Because patient doesn't feel that. So we repolish that. Okay, first polishing. Just with the rubber polisher. And the result is better, but it's not solved. Okay, so we repolished even that premolar. And what happened? Okay, it's much better, but we see another problem. So after the third polishing, we found another contact. Another crown on implant. Actually, just the composite in between the crown and the screw. So we repolished that, and look, immediately bite was changed and released, and she didn't feel the front. We didn't touch that front incisor. And thanks to the digital articulation, we can see those things immediately. So we can treat bruxism in 15 minutes. If it's, let's say, easy case. Sometimes it needs more months. But usually, if there is a problem of 1-2 teeth, it can be immediately treated. So what the digital dentistry brought us? For me, the first thing is efficiency. Time saving for anything you want. Of course, somebody sees, the time saving like, okay, I can do more work. Yes, I tried this at the beginning, and then I realized that I'm slowly dying. No, now I'm trying to save the time to be able to come to Seoul, for example. And of course, it's comfort for patients. They don't need to come several times. They have a lot of things treated immediately. Calls the patient, "Yeah, my tooth is broken." "Okay, come." And it's solved. Bye. See you in 1 year. So another things that brought new methods, new materials, new options. Many years ago, I was asked to be a final speaker on a huge congress where were 1,200 people. And they asked me, you know what, you have to bring those people to the hall. Make something loud. And in that time, I wrote Emacs song because it was the lecture about the Emacs ceramic. I made the Emacs song. If you want to see it, it's on YouTube. Then, before COVID, I did another one. It was on a same congress in Budapest. And when I discussed, what to do for you, for Osstem, because I really like the company, and what I told to Chairman, I don't think Osstem is number one. I think the Osstem is the only one. There is no other company like that. So I thought, okay, you're coming second time to Seoul, make something that nobody will forget. So 2 days ago, I wrote the Osstem song. Actually, I wanted to prepare also the movie, the music clip. Okay, maybe next time. It wasn't enough time for that. I already started, so I can send you the working version. But now, yeah, it is the Emacs song 1. Finalization of the song was on the way from Prague to Seoul. First connecting flight was delayed, so I had a lot of time for that. So finally I finished it, and please enjoy, because I don't feel that strong to sing now, but you will hear me.
This is the first
Please make it loud.
song. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow. Doesn't matter if there's bone, doesn't matter if there's not. Osstem's got some solution, Osstem's got all what you want. Osstem's got all what you want, Osstem's got all what you need. Osstem knows what's the blood clot, Osstem's never let you bleed. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow. Doesn't matter if you're poor, doesn't matter if you're rich, doesn't matter if there's crown, doesn't matter if there's bridge, doesn't matter if you're nice, doesn't matter if you're bad, doesn't matter what's the reason for smiles, we screw it down and make you glad. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow. Doesn't matter if in Seoul, doesn't matter if in Prague, doesn't matter if in Rome, doesn't matter if in Hague. Everybody wants to smile, everybody wants to bite. Osstem knows how to serve you well, Osstem knows how to make life bright. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow. Doesn't matter who you are, doesn't matter where you're from, doesn't matter which you call, doesn't matter there's a storm, doesn't matter what you like, doesn't matter where you go. Now it's time to grab the mic, now it's time to make the flow.
very short crown. So many doctors ask about that teeth endodontic treated before, or how to attach it.
This is that biggest advantage of adhesive restorations, that the prep is very small and very quick, because we don't need to prep too much. We don't need to do endodontic treatment anytime. It's just about the proper shape and proper cementation, and that's why I don't need, or I don't use the zirconia, because you need to have etchable ceramic. So you need to have feldspathic, low-side, or lithium disilicate. Even with all those new hybrids, it doesn't work. It doesn't work itself. So it needs to be bonded to that tooth, but then it really works. It doesn't matter doesn't matter.
Okay.
It doesn't matter what's the size of the tooth.
Okay, the one guy have another question about vertical height. When you do the full mouth rehabilitation in one visit, he said, "I'm not prosthodontist guy, so I don't understand." But he said
how much to increase it?
Yeah, he said, yeah.
This is a very often question. It's a most often question. You know what? I had to go, of course, through all those articulation theories. I have a lot of equipment, all those articulators, face bows, and everything. And then I realized it's simpler than we think. If there is the problem only of those worn teeth, not the problem with the joint at the beginning, you need to set up the teeth into the aesthetic position. So you need to see the patient standing with normal look of the soft tissues with the closed mouth. So you have to set up the bite, but then leave the patient to close, because you will recognize if it's too much or if it's not. It's really the aesthetic way. And of course, if you're not sure, just take some composite, the cheapest flow composite you can get, and just build the first molars to the proper shape of the cusps. And you will see how much of enamel disappeared. So this can be roughly done, and the rest, we are humans, so we can adapt to many things. It's not that strict. It's not that strict like sometimes we read in the books.
Okay, thank you. 그러면 현장에서도 질문 하나 받아보겠습니다. Is there any question from the floor?
I got a question. When we can meet next time?
I'm not the owner of Osstem. Sorry.
Because I like Osstem, that much that really, it doesn't matter if it will be here or in Rome.
But actually, I'm very close with him.
Okay.
Yeah, I can tell him. Okay.
So thank you.
Yeah, but the last question, I just got the very important question. The song you showed, that song is written, the lyrics and the melody?
Yeah, I do.
Whole by yourself?
Actually, I do everything. That's why I need to save the time, because, I have a lot of hobbies. This year I recorded the first LP, because previously it was just the CD, but now it's not modern. So now we're back by the analog. I got a new LP. But soon I will transfer everything to the Spotify and Apple Music and all those, so you will find it. Actually, there is already my old work from 2001, and I wrote even the COVID song during one lockdown. So it's very depressive. It's very how to say that? You will feel like you can't breathe, really, when you will hear that.
I can say it is really addictive. Yeah, I can dream that song today.
Now, just try to find the COVID-19, and or maybe I will later send some QR code.
Okay, you're a really good lecturer. I think you are the pioneer of the future dental clinic. So I hope every dental clinic, as you showed, in the near future, every dentist do like you. So 큰 박수 한번 부탁드리겠습니다.
Please give Dr. Haini a warm round of applause.
I'd like to thank Professor Lee Woo-gyu, who served as chair, and I would like to thank the two excellent speakers. And now, survey on satisfaction on lectures. We want to conduct a satisfaction survey on the passionate lectures delivered here at Osstem Meeting 2022. Text message of it will be sent to all on offline participants. If you click on the link in the text message and fill out the simple survey form, 200 people will receive chicken gift coupons and catch the luck by joining the survey.
Now we will begin the poster award ceremony. Up to October, 162 posters were received. We had received a lot of attention. 16 evaluators went through a lot of debate and evaluation to select the 6 gold prize, the 3 grand prize, and 1 master prize. The prizes will be given by President Choi Kyu-ok. Now let's invite President Choi Kyu-ok to the stage. First, the gold prize of the poster contest at 2022 Osstem Meeting, 500,000 won, an award will be given to the winners. A total of 6 people will be named. Please come up to the stage. I'll call names. Dr. Kang Hyun-mo of Yonsei Dental Clinic, Prosthodontic Department. Dr. Yoon Si-won of Periodontic Department at Ide Mokdong Dental Hospital, and Dr. Hyun Jin-ho of Seoul Gaon Dental Clinic, Dr. Yu Jae-hung of Maxillofacial Facial Department of Jeonnam University Hospital, Dr. Moon Soo-in of Prosthodontic Division at Kyunghee University Hospital, and Dr. Lee Hwa-sun of the Classic Dental Clinic. First, the award will be given to Dr. Kang Hyun-mo of Prosthodontics Division at Yonsei University Dental Hospital. Gold prize for the poster contest. Dr. Kang Hyun-mo of Prosthodontics Department at Yonsei Dental University Hospital. Based on your passion towards dentistry, you have demonstrated a wonderful clinical case. You have been chosen as the gold prize at 2022 Osstem Meeting, Seoul, Korea. Osstem Implant President Choi Kyu-ok, please give him or her a warm round of applause. Next is Dr. Yoon Si-won of Periodontal Department at Ihwa Women's Mokdong Hospital. Poster Gold Award of Periodontal Department at Ihwa Women's Mokdong Hospital. It reads the same. Congratulations. Next is Dr. Hyun Jin-ho of Seoul Gaon Dental Clinic. Gold prize of poster contest. Dr. Hyun Jin-ho of Seoul Gaon Dental Clinic. It reads the same. Next, Dr. Yu Jae-hung of Maxillofacial Department of Jeonnam University Hospital. Mr. Ryu was not able to visit. Gold prize for poster contest. Dr. Yu Jae-hung, it reads the same. Dr. Moon Soo-in of Prosthetics Division at Gyeonggi University Hospital Dental Clinic.
포스터 금상.
Gold prize for the
문수인. 이하
poster
내용
contest. Gold prize. It reads the same.
네, 다음은 더 클래식 치과 이화선.
Next is Dr. Lee Hwa-sun of the Classic Dental Clinic.
포스터 금상. 더
Poster
클래식
gold
치과
prize.
이화선.
Dr.
이하
Lee
내용은
Hwa-sun.
같습니다.
It reads the same.
네, 이렇게 금상 수상을 완료했는데요. 수상
All
소감
winners have
대표로
received the gold
이화선님께서
prize.
네,
Dr. Lee
해주시겠습니다.
Hwa-sun will make a comment on behalf of all winners.
안녕하십니까. 저는
Greetings.
치과
I am Dr. Lee Hwa-sun of the Classic Dental Clinic.
이어서 올해까지 상을 받게
La-
돼서 너무 영광으로
I'm really
생각합니다.
honored to receive an award following my previous award last year. Osstem has really helped me investigate into matters of which I thought was whether it was possible or not. Osstem has provided a lot of innovative products. I'm really honored to receive this award and I will continue to push forward. We'll have a photo shoot for the winners. Please step forward to the stage.
네, 금상 수상자분들 다시 한번 축하드립니다.
Congratulations once again.
네, 다음 시상은 2022년 오스템
First
미팅
award
포스터 최우
will be
수상입니다.
given to the
수상자에게는 상금 100만
winners.
원과 상장이
Along with
주어집니다.
1 million won
호명되는
award will be
순서는
given.
가나다 순으로 총 세
A total
분이십니다.
of 3 people will receive this award.
네. 지금 잠시 네, 금상 수상자분의
We are
사진
going
촬영이
to
진행 중입니다.
wait for the photo shoot for the gold prize winner.
네, 그럼 이어서 최우 수상하도록 하겠습니다.
Now we'll move on
호명되는
to the
수상자는
first
단상으로
prize winner.
나와주시기
Please
바랍니다.
step forward.
연산치과 홍준태님, 이내
Dr.
목동병원
Honjun-tae
구강
of Yonsan Dental Clinic,
김진우님,
Dr. Kim Jin-woo of Oral Maxillofacial Surgery at Ihwa Mokdong Women's Hospital, and Dr. Yoon-suk of Implant Dental Clinic.
네, 회장님 무대 중앙으로 모시겠습니다.
So the chairman is invited to the center of the stage.
먼저 연산치과
First, to Dr. Chun Tae-hong from Yonsan Dental Office.
포스터 최우 수상.
First prize of poster, Dr. Chun Tae-hong. The certificate of merit is conferred to you for your excellent clinical case presentation, as it is selected to receive the first prize in 2022 Osstem meeting, Seoul, Korea, November 20th, 2022. Chairman Kyok-chae of Osstem Implant. Please give him a big round of applause. Next, Dr. Jin-woo Kim, Oral Maxillofacial Surgery of Ihwa Women's University Mokdong Hospital. He is absent today, so
이내 목동병원 구강 아간면외과
Dr.
김진우.
Jin-woo
이하
Kim,
내용은 같습니다.
Ihwa Women's University Mokdong Hospital, and on behalf of the doctor, somebody else is receiving the prize. And the next, Dr. Eun-suk Lee of Implant Dental Office.
포스터 최우 수상.
Poster first prize,
이은석.
Dr. Eun-suk Lee of Implant Dental Office. It reads the same.
네. 세 분 모두
So congratulations to all all three winners. I would like to invite Dr. Eun-suk Lee to give us what he's feeling after receiving the prize. Thank you very much for giving me the opportunity to make the presentation and for giving me this prize. And I would like to thank the judges who have been working all day from morning. And today, this is quite rich Osstem meeting with a lot of Osstem products, and we have many foreign guests here. And Osstem is moving beyond the local market, and I hope Osstem implant would become a worldwide K-implant company. And I would like to thank my mentor, Dr. Park, Dr. Ho, and others who have guided me to this position. So let's have a photo session of the poster grand prize winners. I mean, the first prize winners. First prize winners, congratulations again. Next, the best poster is selected for 2022 Osstem Meeting Poster Grand Prize. 2 million won and certificate of merit is to be conferred. Who is the winner of the grand prize? The winner is Dr. Hyun-min Lee, Periodontal Department of Chosun University Dental School. Please welcome him with a big round of applause.
포스터 대상 조선대학교 치과병원 치죽과 이현민.
Dr. Lee Hyun-min of Chosun Dental Hospital. Based on your passion for dentistry, you have demonstrated an outstanding clinical case at 2022 Osstem Meeting Seoul, Korea, and you have been awarded with the grand prize. November 20th, 2022, Chair of Osstem Implant, Cheguk. Please give him a warm round of applause.
네, 이어서 수상 소감 부탁드리겠습니다.
I would like to hear a word from you. Greetings, I am Periodontal Department at the Chosun University Hospital. I would like to thank my mentor, Professor Lee, as well. I look forward to good products from Osstem. I will continue on providing good treatment to my patients. We will have a photo shoot session. We will have a photo shoot with Mr. Chegyok of Osstem Implant, the chairman. Congratulations once again. We will now conclude the poster award ceremony for 2022. I would like to congratulate all awardees once again, and I would also like to extend my gratitude to Chairman Chegyuk for giving out awards. Digital Dental Technician Contest and Osstem Meeting 2022 Seoul have been with us following yesterday's event, and today we are towards the end of our wonderful ceremony. I wish it could last longer. In light of such feeling and sentiment, we have a fabulous event. I'm sure a lot of you have been waiting for this highlight event. Three winners will be given Galaxy Buds 2 Pro, 2 will win Galaxy Watch 5 Pro, and 1 person will win Galaxy Z Flip 4. Lucky draw will be done because a lot of people have 2875 in their phone number. We're going to go through lucky draw in the middle part of the cell phone number. If there are multiple, if there are overlapping numbers, another number will be drawn immediately. Let's start the lucky draw from the third prize. The third prize, Galaxy Buds 2 Pro.
네, 현장에 계실지 오프라인으로 만나뵐지. 네.
461868.
8번. 네. 461868번.
461868.
다음 번호는요.
Next. 282339. 282339. Congratulations. You've been awarded with the third prize, Galaxy Buds 2 Pro. Third but not least, 474849. It's a unique number, 474849. Congratulations. Next is the second prize. You'll be able to win Galaxy Watch 5 Pro. Who will win this fabulous prize? Congratulations. 529049. 529049. Galaxy Watch Pro. The second winner. 529297. It's similar. 529297. You're the winner of Galaxy Watch 5 Pro. Now there's only the final grand prize. Who will win Galaxy Z Flip 4? $222,620. Congratulations. You're the winner of Galaxy Z Flip 4. The first Digital Dental Technician Contest and Osstem Meeting 2022 Seoul, which has been continued for 2 days in November 19th and 20th, is now coming to an end. Osstem Meeting 2022 Seoul has continued to lead the development of digital dentistry along with other dental advancements in Korea and in overseas countries as well. I hope you have had meaningful lectures from prominent speakers at home and abroad. I'm sure you have learned a lot through the live surgery. We will now have a award ceremony and offline lucky draw after the ending video. Stay with us till the end and perhaps you'll win. I'd like to thank once again for the chair, speakers, and the audience who are with us today. Now I will close this session. I'm announcer Kim Yoo-soo. Thank you for being with us.
네, 그럼 이어서 공로상 수상 진행하겠습니다.
Now,
그동안
award will
공로상을
be
수상하신
given to
분들
those who have
잠시
dedicated
소개해드리자면
heart for
2013년
Awesome Meeting
조용석
Seoul.
원장님,
First, we're
2014년
going
정창호
to
교수님,
introduce
2015년 조규성 교수님, 권종진 교수님, 2016년
the previous winners. In 2013, it was Dr. Cho Young-suk. In 2014, it was Professor Cho Chang-mo. In 2015, Professor Cho Kyu-sung and Professor Kwon Jong-jin. In 2016, Dr. Lee Kwang-hun. In 2017, Professor Cho In-ho. In 2018, it was Professor Kim Myung-rae and Oh